Welcome back. I think I've checked certain things and it works well, not a problem. So it must be fine. So if people are there, then we can start again. Okay, waiting for the participants. Yes, thank you very much, Shravan, Srikanth, and everyone. Back. Yeah, I've just went to check if everything is all right. So we are making sure that things are going to be uploaded by within night or maybe within tomorrow morning. Yeah, I think I've been writing very slowly only. Is the pace right? It's not speed. It's not. I'm not going very fast, right? So I'm going in a perfect pace right now. Okay, all right. So I don't think there will be an issue. Okay, cool. Okay, and Riju is asking, what do you mean by S1 in the septal blood supply? S1 is the first septal branch. I mean, for example, if you go back to the image, I cannot, purposefully, I'm not drawing again and again. I mean, in the sense, like, I'm not saving it because I need to use it for other class as well. Missed that fun in the live class. Like I cannot do that here anyways. So otherwise the show will become something else. Voice is becoming low in between. I think that will get better. Yeah, Parkinson faces drowsy students. Too much fun. Okay, fine. So somebody's asked what do you mean by S1? S1 is very simple, like, so this is a LMCA. LMCA goes to produce this left circumflex. You have an LAD, so left anti-descending. Like from there you get something called a first septal branch. This is nothing but S1, so it is nothing but the septal branch. So the interventricular septum is going to be somewhere over here, right? I mean, I'm just telling as a conceptual basis, interventricular septum is going to be here, and this interventricular septum will be supplied by the septal branches, so called as S1, S2, S3, and so on. On the other hand, the main left ventricle, anterior wall, and the apex will be predominantly supplied by the diagonal branches like D1, D2, D3, and so on. So that's fine. Okay, cool. Uday Bhaskar is attending again, I think. Okay, fine. All right. So with this, let us move on to the lead system where we left some time back. So as with the lead system is concerned, so you're going to have three different leads. One is called to start with, you have the left atrium, right atrium, and the left left lower limb. That is the left leg or the left foot. From this, we can derive certain leads. For example, it's all about assumption. The machine assumes that, but we have to just understand what the machine assumes. So if we take this as the negative and this as the positive lead, and the current is going to flow from a region of negative to the positive. So if you construct a lead like this, and this lead will be called as something called a lead 1, we know that. And suppose if you take the right arm as negative and the left leg as positive, so let me draw in a different color. So right arm as negative and the left leg as positive. And if you assume that, and you're really not going to do that, just for concept you're doing that, but the machine is going to assume if the right arm is negative and the left leg is positive, then you're going to push something like this from right arm to left leg, and this lead will be called as lead 2. We know that. And if you're going to assume the left arm as negative now and left leg as positive, now the current is going to flow something like this from negative to positive. So this will be called as lead number 3. So these are the Einthoven's leads basically. And if you really see what's happening over here, so these leads are called as unipolar leads or bipolar leads. Let me give you a clue. So it's going from negative to positive, negative to positive. For example, like from North Pole to South Pole, so negative to positive. So these leads will be called as bipolar leads or unipolar leads. People can, if you are willing to answer, you can answer. So what is this type of leads called? This lead 1, 2, 3, whatever I've drawn will be called as, yes, basically bipolar leads, because it starts from negative and ends in positive. You have two different poles. So that's why you have 1, 2, 3. They're called as bipolar leads. And from this, you can derive certain leads like unipolar limb leads also. for example, you can take this point. If you take this point, it's like, center point between the positive and the negative that you're dealing with. So if it's a center point between positive and negative, this point you can call it as 0, of course. And similar to that, in this area, from between the right arm and the left arm, if you take the center point, of course, this point is also going to be 0. And if you take the center point here, so positive and negative, and the center of it, of course, must be 0. So this is also 0. And by a simple rule of mathematics, if you draw a perpendicular to all these things meet at a common place. And this point also is going to be 0 because it's meeting of 3 zeros. And 3 zeros, if they meet, of course, it's going to be a bigger 0. And that 0 is what we refer to as something called a Wilson central terminus. Clear? So if I'm going to take a 0 point, that is a Wilson central terminus from this zone, and if I'm going to draw a lead towards a particular lead, for example, if I draw towards this lead, if I'm going to assume this as 0, and if I assume this right arm as positive now I'm creating a new kind of a lead. So this is a new lead. So I'll be calling it a different name called as something called an augmented lead called as AVR. So since it's moving towards the right arm, this will be called as an augmented limb lead, that is A, V, and R. And I can also do similar things like this. So from this 0 point, I can make this as 0 and again this lower limb as positive, and I can push another lead from the 0 point towards the leg, and this will be another augmented lead or a derived lead from this basic 3 leads, 1, 2, and 3, and this is called as AVF, that is the foot lead. And at the same time, I can also derive another lead. Let me use a different color. So from this, if I use this as positive now, the machine is going to assume this left arm as positive, and if you derive a new lead from this 0 point towards the left arm, and this will be called as AVL. So these are the 3 augmented leads. So now you can really understand that all these leads are basically starting from a 0 point, not from a minus value. They're starting from a plus value. So if they're going to start from a 0 point, not from a minus point, and they're going towards a positive direction. So this 0 to plus, not from minus to plus, 0 to plus will be called as unipolar leads or bipolar leads. Of course, this will be called as unipolar leads. So, understanding is quite simple. So you need not waste much time on that. So the idea is to know that this is something called a Einthoven's triangle, and this is something called as there is something called a Wilson central terminus, and you have something called a bipolar lead and a unipolar lead. Basically, as far as the 12 lead ECG system is concerned, so you're going to have 2 types of leads in the 12 lead ECG system. The first type of lead is going to be the limb lead, and the second type of lead is going to be the chest lead. So as far as the limb lead is concerned, so we have the original bipolar leads, which are the first ones to be discovered by Wilhelm Einthoven. Augmented leads are, I'll come back to that. Wait. So just, this is not a very difficult concept, but still it needs some repetition. So I'll tell. So bipolar leads. And if it's a bipolar lead, it's going to be of 3 types. So you have 1, 2, and 3. These are the bipolar leads. And of course, you are going to have the unipolar leads, which are nothing but the augmented leads. You have AVL, AVR, and AVF. So these 3 are going to be the unipolar leads. We know that. So bipolar and the unipolar leads. And of course, we do have the chest leads as well. As far as the chest leads is concerned, you're going to have different kinds of leads like V1 to V6, which we'll be discussing subsequently. Remember, as far as the limb leads are concerned, they are fixed. You cannot change because you have only 3 limbs. So you cannot really change that. And within the 3 limbs only you have to play. And there have been a lot of research on one more additional lead that's called a minus AVR. So this is an additional lead. So the utility of minus AVR is being proven in certain studies and researches, but this minus AVR, we're not talking about plus AVR, this is the plus AVR we're talking about. Minus AVR is also there. So where they try to take this 0 point and go somewhere like this here. So that's a minus AVR lead, but that's not important right now. And just to know that if we can keep an additional lead called as a minus AVR. But overall, as far as the exams are concerned, the limb leads are fixed, you cannot change, and only 6 leads are there in the limb leads, that is bipolar leads of 1, 2, and 3, and unipolar leads are augmented limb leads of AVL, AVR, and AVF. Why it's called bipolar? Because it's traveling from minus direction to plus direction. Why it's called unipolar? Because it's traveling from 0 to plus direction. That's why it's called unipolar leads. As far as the chest leads are concerned, it is V1 to V6. Now we need to know where we have to place the chest leads. So what are these limb leads basically? And what is the lead system, to be honest, to be precise? To understand a lead system, you need to know how they look at the heart. So that is what the lead system is all about. For example, if somebody is looking from my front, obviously you will call it as a front view, but I would like to call it an anterior view in anatomical term. Somebody is going to the side of me and seeing, it will be called as a lateral view. Somebody is going on the top, from the top they are seeing me, it will be called as a superior view. And somebody is going under my chair and now they are seeing me, that will be called as an inferior view. So this lead system is nothing but how they look at the heart. For example, we have seen the Einthoven's triangle, but Einthoven's triangle is not going to help you in your understanding. So we have to draw a kind of a heart. So if I'm going to draw a kind of a heart like this, so if I extrapolate whatever the leads I've drawn till now, so let us draw the limb leads first. You have something called a lead 1. From the center point is going to look like this. Then we have a lead avial, which is going to look like this. And we have a lead 2, which is going to look like this. Then we have a lead AVF, which is going to look like this. And we have a lead 3, which is going to look like this. And we have an extreme lead called AVR, is going to look like this. So if you see, these leads are basically looking the heart from a proper direction, but this AVR is the one that sees heart from a completely, different direction, and that's why it's called an extreme lead. It's like opposite direction, it sees the heart. So 1 AVL, 2, 3 AVF. So these are the most important leads, and AVR, of course, is increasingly recognized in view of this left mainstem disease and triple vessel disease and all, which we'll be discussing subsequently. So these are basically the limb leads. In that we have the 3 bipolar leads, and we have the 3 augmented limb leads. Those are the unipolar limb leads as well. Okay. After understanding all this stuff, okay, missed lead. Okay. So what is the color coding? So as far as the limb leads are concerned, you have to know the color coding. So I'll tell you why it is important. So before that, let us see the color coding. So what is the color that you will prefer? Usually the left arm will be given in black color, and right arm will be in the white color. And the right leg, you also have a lead. So what is this lead? This is a neutral lead. So usually it will be a green color. So this is not important. So that is connected to the earth. You need to have a neutral lead. So that's a green color. And you have the left leg, so which is going to be red in color. So these are the color coding. So left arm, the lead that you're going to place on your left arm will be denoted by black color lead. So that having a black color, and the right arm will be denoted with a white color, and the right leg is a neutral to the earth. So that's like a 0 neutral lead, and that will be having a green color, and the left leg will be having the red color. So these are the color coding. And sometimes, like with the current kind of questions that you're getting in exam, this could be a very important question for your exam, because this is very important, because many times the staff nurses do something called a lead reversal. So which means they place the left arm and the right arm, and so much confusion they do. So to know this lead reversal properly in exams, they might give these kind of questions where you need to know about the color coding properly for that. So clear. So what are these basically? So you can see that these leads are basically seeing the heart from different directions. For example, if you take these kind of unipolar and bipolar leads, are the limb leads, they are basically seeing the heart from this particular direction. For example, you can tell it's a coronal plane, not exactly, but you can see like a coronal plane, where these leads see the heart from the frontal plane axis. So whatever leads I've told you, the limb leads are basically corresponding to this, something called a frontal plane axis, or simply I can write as a frontal axis. But heart is a 3-dimensional structure. It's not a 2-dimensional structure. You have an axial view of the heart as well. This view is fine. This view I am trying to see in the coronal plane. Maybe your mission might be different. See, this is a universal color coding which you're talking about, Sony. We are not talking about color coding that is seen in your particular hospital, because it varies from mission to mission, and it can vary from an apparatus to apparatus as well. Even the chest leads have some color coding, but this is a universal color coding given by the like you can go to the Philips website and see this is a universal color coding basically. And even ACCHA website also has this, but it is not a standard, and you can actually change the colors. That's up to you. So it's all about whether the mission is given properly or not. That's what the question is. Fine, all right. So this is a coronal plane, and you have this axial plane also, and the heart has to be viewed in that axis as well. So this is what we refer to as something called a horizontal axis. And if you want to really know what really happens in horizontal axis. That's why we have the chest leads. So which means chest leads are going to basically see the heart from the horizontal plane axis. So that's what this V1 and V2 is going to do. So if I want to keep these leads, I'll be keeping from here. For example, let me assume this is going to be the V1, this is going to be the V2, and this is going to be the V4, and V3 will be placed somewhere in between V2 and V4. And of course, I'll be writing V5 and V6 here, which means in the chest, I am placing the chest leads on the horizontal direction. So they're going to see the axial axis or the horizontal plane axis of the heart. So if you really want to know where this V1 and V2 will be placed, V1 V2 will be basically placed in the parasternal region, in the right and the left parasternal region, in the fourth intercostal space. That's why it's important. So which means basically they'll be placed in the fourth intercostal space in the parasternal region. So for example, in the right and left parasternal region, immediately next to the sternum. So that's why they'll be placed in the fourth intercostal space. Then as far as V3 is concerned, V3 does not have any specific location, and V3 will be just placed in between the V2 and V4. Then we have the V4, V5 and V6. V4 and V5 and V5 and V6 will be placed in different directions. For example, V4 will be placed, all these will be placed in the fifth intercostal space. We know that. And V4 for that matters will be placed in some area called as the mid-clavicular line. And V5 will be placed in the same fifth intercostal space. As the intercostal space moves towards the lateral side, it will be placed in somewhere called anterior axillary line. And V6 will be placed in the mid-axillary line. Clear? So this is where V4, V5, V6 are going to be placed. So this is the proper anatomical location of these leads. This is where it should be placed for a proper understanding and proper development of the ECG. And if you know what you mean by Einthoven's rule, which you have not discussed till now, so what do you really mean by Einthoven's rule? It's a huge formula, it's a mathematical derivation, but it holds true even now, even in the modern century. So you have 1 plus 3 is equal to 2. So this is what we refer to as an Einthoven rule. And this has to be mugged up, definitely. There's no doubt about that. This is very important, quintessentially very important for exams. And or you can write 1 plus 3. If you bring this 2 this side, it will become minus 2 is equal to 0. So which means when you add all the voltages of the leads, 1, 2, and 3, it's going to be equal to 0. This will be true. Suppose if it's not equal to 0, then you're not placing the leads symmetrically. That's what it means. Which means if you're placing a left arm lead here, right arm lead also should be placed on the wrist. Suppose if you place a right arm lead maybe on the arm, and if you place a left arm lead on the wrist, so what you're basically doing is creating a type of an asymmetry. Now the triangle will not be a perfect triangle. So now there will be kind of an asymmetric triangle. So your Einthoven's rule may not be satisfied in that scenario. Or if you do some case of a lead reversal, then again Einthoven's rule may not be satisfied, where the augmented limb leads and all the other limb leads will get completely different and they'll form a mess. So whenever you don't satisfy the Einthoven's rule, you look at two things. Either you're not placing symmetrically and the triangle is not symmetric, or probably you are not placing the correct leads in the first place. Your arm leads are misplaced or doing some misplacing of the leads. That's what it means. So this is a very important rule and you have to know for the exam. This is what we refer to as something called a Einthoven's rule for that matters. So what these lead systems are basically doing, we know that. So these leads are basically seeing the heart from a particular perspective, as I told you. So for example, if you see this 2, 3F, let me rub this off. So because this is not needed anymore. Let me take this off. Okay. Now I removed that. So what these leads are basically seeing, for example, if you see this 2, 3 and AVF, you can clearly see they are seeing the heart from the inferior direction. So if you're going to see the heart from the inferior direction, these are called as inferior leads. Clear? Yes, leads can be placed anywhere. Even you can place the leads directly over the heart. It's not like you can place only 20 centimeters away from the heart. So you can, if you can place in a proper location, you can even place the leads directly over the heart also. So it's not like you cannot place a particular lead. We're talking about the limb leads here. So yes, of course, minimum it should be placed in the shoulders at least. So for example, you would have seen in the ICU where the strips are running basically. So where you cannot really keep this kind of big leads and monitor the patient in the ICU. So the ICU have this kind of sticking kind of lead. So where they stick on the right arm, left arm, and the left leg. I mean, they don't go up to the left leg, but they will be keeping in the hip region, probably near the left subcostal region. They'll keep on lead, and this will form the 9th ounce triangle. And now you're going to get the 1, 2, 3 AVL, AVR, AVF. That's fine. That's all right. So anyways, fine. So let us move back to what we are supposed to discuss. So we have something called inferior leads, the 2, 3 AVF. They see the heart from the inferior direction, from down. And we also have this kind of V1, V2 called as septal leads. So they look at the interventricular septum, and V1 is the only lead that probably sees a little bit of right ventricle. But apart from that, other leads don't really see the right ventricle. And V1, V2 predominantly see the interventricular septum. V1, to an extent, they see the right ventricle, but not much. And you can see that V3 and V4 principally see the anterior left ventricle. So we can call it as anterior wall is seen by the V3 and V4. And we have the V5 and V6. Which are basically see the lateral wall. We can call it as epicolateral or just lateral. And 1 and AVL also see the lateral wall, but a little bit higher on the left heart. So these are called as high lateral leads. So in general, if you want to know what are the lateral leads, this V5, V6, and 1 and AVL will be called as lateral leads. So these are the lateral leads basically. Okay, fine. So we have the septal leads, we have the anterior leads, we have the inferior leads, we have the lateral leads. In that we have the epicolateral and we have the high lateral, 1 and AVL. And AVR is an extreme lead. It's a northwest lead, which we'll be discussing. It's also useful in certain scenarios, but especially in the diagnosis of ventricular tachycardia, which we'll be discussing subsequently. So AVR, extreme lead. It sees completely in opposite direction. So this is the lead system that we have to know about, because this is going to be very helpful when you're going to diagnose a STEMI. So remember, when you're going to think about an ischemic heart disease, or probably like myocardial infarction for that matters. So whenever you take an ischemic heart disease, you have two types of ischemic heart disease. One is called a stable ischemic heart disease, which will be called as angina, and unstable ischemic heart disease, basically it will be called as an acute coronary syndrome, right? So before talking about the STEMI, it's also important to know about how will you classify an ischemic heart disease. Ischemic heart disease can be classified into angina, simple angina. That's a stable ischemic heart disease. This is stable angina. Second, you have this kind of unstable anginas. So in the sense, I'm just going to call it as a acute coronary syndrome, which means it's not a stable disease. I mean, the details of which I'm going to discuss separately in the ischemic heart disease section. But right now, trust me, this is really, really important. So as far as the ACS is concerned, you have two different types of ACS. One is called ST elevation myocardial infarction, or otherwise simply I can call it as ST ACS, which is a modern nomenclature. And we have the NSTEMI unstable angina complex. To avoid the confusion, because of unstable angina has a different definition, so they have just called it as NST ACS. And there are a lot of differences between ST ACS versus NST ACS, which we'll be subsequently discussing in due time. But more importantly, 2 points are important. ST ACS produces a transmural ischemia. If it's not treated properly, that will become a transmural infarction. Infarct means a dead tissue. That's what we call it as infarction. If you talk about the NSTEMI unstable angina complex, or NST-ACS, so it produces only a subendocardial ischemia due to variety of reasons. It will not be a transmural ischemia. Full thickness will not be affected. Only the subendocardial portion will be affected. If it's not treated, once again, it can go for subendocardial infarcts. Most of the times, you have to understand that ST-ACS is supposed to be mostly focal because of single vessel involvement most of the times, whereas NST-ACS is supposed to be multifocal because they usually produce something called a phasic distal embolization, where distal parts of many vessels can be affected and blocked, and that's why it is a multifocal disease. So that is also one reason why, because these are going to show ST elevations and these are going to show ST depressions or probably T-wave inversions. Remember, these ST elevations can be really localized. You can localize the ST elevation. But whereas when you talk about the ST depression, you cannot localize. It cannot be localized in the first place, because how can you localize a multifocal stuff? It's already multifocal. You cannot really localize. So, but ST elevations can well be localized because this transmural ischemia is going to be extremely focal in a particular area, and that can be very well localized. Let us see how this really happens. And first of all, you need to know what is an ST segment. So I'm going to discuss a whole lot of detail about what is an ST segment later on also. But because we have understood the anatomy better now, because I have discussed a lot about anatomy before, and I've discussed a lot about the lead system. So right now is the best time to tell about the like different localization of the STEMI. Reason for depression, elevation, relation to hypoxia, ischemia, necrosis. That's almost a very simple stuff, but that's really not needed for exams because nobody is going to ask that. But maybe I'll try to explain maybe in 2-3 minutes if possible. Okay. So what we are discussing? So we're discussing about STACS versus NSTACS. In that matters, we wanted to localize a STEMI. So for that, you have to understand what you mean by ST segment. For suppose if you take a lead, everyone would have seen this kind of a lead. So here you have the P wave, you have the QRS segment in the ECG, and you have a T wave. And if you want to tell where the segments are the isoelectric points. So this is the PR segment. So remember, it's a segment. Whenever you talk about a segment, it must be isoelectric, straight line, flat line. And we have a ST segment over here. So this is the QRS complex, and end of the QRS is S, and you have the ST segment here. And the junction of the ST segment with the QRS is what we refer to as something called a J point, of course. So which means ST segment and PR segment both are basically isoelectric. In that, ST segment has to be isoelectric. That's a rule. It's a straight line. But what happens in the setting of ischemia? It's completely different. So for example, let us assume a transmural infarction. Or before that, let us assume why you get the ST segment in the first place. So let me draw a heart in the first place. So if you want to draw a heart like this in the first place, you know this is going to be the left ventricle and this is going to be the right ventricle. Suppose if I am causing some transmural ischemia. So this is what a typical STEMI is. I'm going to have a transmural ischemia. The full thickness of that particular area will be going for ischemia. If you don't treat it, they will die. So that's called an infarction. So you're going to get a transmural ischemia. This transmural ischemia basically will generate something called an injury current. So you must be wondering, so what do you mean by injury current and why you generally create an injury current? It's because of the poor activity of the sodium potassium ATPase. You know, whenever there is an ischemia, there will be reduced ATP production. And because of the reduced ATP production, you know, like your membrane permeability will be very poor. In the sense, usually during depolarization, only your ion should enter into the cell, and during resting state, there is no net movement of the ions. For example, if you ask about what is the resting state of the cell, if I take this is the resting state of the myocardium, you're going to have like relatively no charge. It means you're going to have a negative charge from the inside. That's why the RMP is always negative, and outside it's going to be relatively positive. Remember, everything in medicine is relative, and you should never ever confuse this negative and positive in absolute terms. Inside is negative relative to the outside, and outside is positive relative to the inside. That's how you have to remember. So this is the resting state. Then once you're going to produce something called a depolarization, so the things are going to reverse. The polarity is going to reverse, and it's going to propagate. So some of the areas inside will become positive, and some of the areas outside will become negative. But let us assume this is propagating now, and a lot of other areas are still not getting depolarized in this particular membrane, which means I can still write a lot of inside portions are still negative and the outside portions are still positive, which means this is the exact point, which means this is the propagation of the depolarization. You can see this is where the depolarization propagates, and during this time only you're going to get a deflection, or maybe positive or maybe negative. I'm not telling that topology now. So this is where you're going to get a deflection in the leads. So which means during the time of propagation only you're going to get a deflection. Suppose if the depolarization is complete, let us assume completed depolarization, what will happen? Completed depolarization, you are going to get full positive inside, which means the entire cell and the entire membrane has become depolarized and the entire outside has become negative. This is a full depolarization. And during this time, if you get any deflection or not, you will not get any deflection. That's really, really important. And this no deflection point is where you get some isoelectric segments. So like for example, an ST segment, this is formed during the no deflection kind of a point only. And after that, this kind of completed depolarization, you are going to start the repolarization. Repolarization, of course, we know it's going to be reverse. So if you ask about repolarization, it's going to start from here to here. So let me draw that. So some of these areas will become negative again, and some of these areas will become positive again, like how it is used to be in the resting state. But you can still see some of the areas are not fully repolarized, which means now only the repolarization is propagating. So during the repolarization, it's going to be in the reverse direction. Always depolarization in one direction means repolarization will be in the opposite direction. So at this point, you're going to get a deflection again, and this is going to produce a wave, like for example, a T wave. What you're seeing in the ECG. So once the repolarization is complete repolarization, they come back to the resting state, which means now everything outside will become positive once again related to the inside, and everything inside the cell will become negative related to the outside. So at this point, once again, you don't get any deflection. You don't get any things in the ECG, and this is the isoelectric point once again. So this is very crucial to understand, which means in a state of completed repolarization, you will have an isoelectric segment only, and you have a completed depolarization, and during this time you will get an isoelectric segment only. You will not get any deflection. Only during the propagation of depolarization, that's where the current propagates. Only the propagation of repolarization, that's where the current propagates. That's where you're going to get a electrical current in the first place. So if you really want to extrapolate this into the ECG, so you have a P wave, QRS complex, T wave, then you have another P wave, QRS complex, and a T wave, like this and so on. So if you see, this is a time of ventricular depolarization, which means this is the point of QRS, which denotes the time of ventricular depolarization, which means that is the time where the waves are basically propagating. Probably this is the time of ventricular repolarization, because this is the time where the ventricular repolarization is producing the T wave. Suppose if we take the isoelectric segments, for example, this TP segment is a big isoelectric segment. That's very important for our understanding. So that's an isoelectric segment. That's a TP segment. And during this time, the repolarization is complete. So for example, if you ask where this area is there, so this area will be happening at this place where the repolarization is complete and the cells have come to the resting state. So for example, if you want to extrapolate here, I can write this is the place of completed repolarization. Clear? Similarly, if you want to know what is the ST segment, the ST segment is a zone. I mean, if you really want to extrapolate from this, this is the time where you get the ST segment, which means your depolarization of the ventricles is complete, which means it's a completed depolarization. During the depolarization, you will get the QRS all right, but between the depolarization and repolarization, you will have a completed depolarization state, full depolarization of the ventricle, where you will not get any current at all, and that's what we call as the ST segment. So that explains you why you really get ST elevation and ST depression, which means during the complete depolarization, there should not be any electrical current going on, which means there is no net current flow. That's really, really important, which means during that kind of isoelectric points where there will be a completed depolarization or a complete repolarization, you really don't get any net current flow. So that is why you get this kind of deflection. Suppose if you are going to have some kind of current flow, of course, this is a TP segment. So this is a TP segment only. So this is a T wave, this is a P wave that starts with. So that's a TP segment you're talking about. So there is no net current flow. So if you do not have any net current flow, you'll be having an isoelectric segment only. Suppose if you have any net current flow during the isoelectric segments, that isoelectric segments can be elevated or can be depressed. And who's going to produce this kind of net current flow? Typically, your injury currents. So these kind of injury currents are going to happen in the setting of ischemia. So why you should get an injury current? Very simple, because you have low ATP, you will be having reduced activity of sodium potassium ATPase, number one. At the same time, you're going to have reduced activity of ATP sensitive potassium channels. Let me tell you what you mean by that, ATP sensitive potassium channels. So both of these things can be the main reason why you are generating a lot of current flow. So for example, if you are having reduced activity of ATP sensitive, sodium potassium ATPase in the first place. So what sodium potassium ATPase does, if you take the cell membrane and see what they do, sodium potassium ATPase, if you keep the sodium potassium ATPase like this, these are going to push the sodium to the outside, and they're going to push the potassium to the inside in the ratio of 3:2. That's why it's called a 3 sodium 2 potassium ATPase. And whenever you have reduced activity of this sodium potassium ATPase, you're going to have more sodium accumulation inside compared to the other cells. So which means they are having a net positive charge compared to the other cells. For example, let us take a group of cells. So let us extrapolate this hard and see, and let's see what happens here. So let me take group of cells. So I have taken 3 group of cells now. Let us assume this particular area is the one that is injured. So if that particular area which I'm showing is injured, and they are, for example, at the end of completed depolarization, or probably at the end of completed repolarization, remember the net electrical current flow should be 0 because all of them, for example, let us assume they are negative. They are negative because they have completed the repolarization. So now at the completed repolarization state, every of the cell should be having relative negativity inside compared to the outside, but this particular area will not remain negative and they will remain positive because of the mechanism I told you here. Because the mechanism I told you here, reduced sodium potassium ATPase activity, they are going to have more sodium inside and they're going to have more positive charges inside compared to the of the outside. So they're going to show a net positive charge. So in the complete repolarization phase, if this also would have been negative, then not a problem. So there is no net electrical flow. Now this area has become positive, and because this area has become positive, now you can see that this is going to share its potential towards others. So which means this movement of potentials to the other cells is what we refer to as a current, and this is how you develop something called an injury current. Clear? So that area of like ischemic area, so that's the one that's going to produce this kind of electrical currents, and that's what is going to happen here. So and that is going to create a type of a current called as an injury current. So this injury current is the reason why even during the completed repolarization phase, it's going to push the baseline. For example, at the end of completed repolarization, we know this is going to be the TP segment of the next interval. So this TP segment has to be isoelectric. But what it's really doing is, this is producing a new current at the baseline. At the baseline itself, you're having some kind of a, it will lead to arrhythmias. Let us discuss about. That's why ischemia, it's one of the important reasons for arrhythmias. So in fact, one of the most common reasons for arrhythmia, whenever the patient comes with any ventricular attack arrhythmia, the most important thing you have to rule out is cardiac ischemia. Very important cause. I'm not telling it will not lead. So you're going to have something called a TP segment. And what's really going to happen is, depending on the propagation of the current, this TP segment is going to get elevated or it's going to get depressed. So that's what is going to happen. So you want to show the ATP slide. So what ATP slide? This is what the ATP slide I showed. There's nothing else I've described. It's very simple actually. You can review it later also, not a problem, doctor. So the TP segment can be elevated or can be depressed, right? As simple as that. So what really happens? Let us take two conditions here. So you take heart. My hearts are really, really bad. Let me take two conditions here. So one is, I'm going to talk about a transmural ischemia, first condition. And second condition is where I'm going to discuss on the subendocardial ischemia. So let me take a second area. So where I'm not having transmural ischemia, but I'm only having some subendocardial ischemia here. So of course, we know what you mean by injury current. So this injury current is going to travel from one direction to different directions. For example, if you have a transmural ischemia, this injury current cannot go like this, because already in the side also you have some infarcted myocardium. Injured myocardium. So this injury current have to travel something like this. Something like this to other areas. So this will be the flow of the injury current. So if this is going to be the flow of the injury current, so if I want to draw the net vector is going to be in this particular direction. So because it's traveling from this area to the other myocardial muscles. Suppose if you take the injury current here in a subendocardial ischemia, it can easily travel to the surrounding myocardium because it's only a subendocardial ischemia and not a transmural ischemia. So the injury current here is going to travel in this particular direction. Suppose if I have a lead at this point, in a transmural ischemia, this injury current will produce a negative deflection because it's moving away from that lead. Suppose if I have a lead over here, and this injury current will produce a positive current, like I can write a positive current flow that is actually traveling towards the particular lead. So, but you would have studied that transmural ischemia is going to produce ST elevation and subendocardial ischemia is going to produce ST depression. But the current is negative here, and here the current is positive. How is this really possible? So for that, you have to clearly understand that we are talking about a TP segment. In the sense, like we are talking about an isoelectric point or the baseline. That is where the problem is. So during the full depolarization, remember, during the depolarization, this area also will be depolarized. during the completed depolarization. And this area also will be depolarized. So during depolarization, there is no much net current flow. It's going to be the same during the completed depolarization. But during the completed repolarization is where the problem is, because during the completed repolarization, the net electrical activity should be 0 in the TP segment. But in the case of injury current, because in the case of ischemia, they are producing injury current, in the completed repolarization is where the problem is, because they are going to produce some kind of current towards the other myocardium. So which means it's the TP segment that is going to be elevated depressed. So let me draw the image here. So if you take this is going to be the baseline ECG. If it's going to be a transmural ischemia, what's going to happen? This is going to produce a negative current at the TP segment, which means at the completed repolarization. TP segment at the completed repolarization, which means if I want to really draw the complete repolarization, this is going to be the baseline. This is going to be the isoelectric point baseline. And for example, these areas also are before the ventricular depolarization. So I can tell all these areas are isoelectric at this point before the depolarization starts. So now what's going to happen is, because this is going to produce a negative current, this is going to push the baseline down. So the baseline is going to go down completely. So if the baseline goes down completely, what's going to happen is you're going to get something like this. Clear. So what you're really seeing, so because the baseline has come down, so you are seeing something called an ST elevation here, which means the ST segment is not having any impact here because it's a completed depolarization stage. But at the end of completed repolarization, because of the injury current is producing a negative current, it is pushing the entire baseline down, except the ST segment, which is going up. That's why we get an ST elevation. So this is all because of the injury current. So because here in transmural ischemia, actually it is moving away from the injured area. So it's producing a negative current. Negative current is pushing the baseline itself down, except for the ST segment, which is going up. That's why we get an ST elevation. Suppose if you, what you see in ST depression, it's very simple. Let us come back to the ST depression. In the ST depression, this injury current is going to move towards that particular lead. So which means at the completed repolarization stage, once again, if I want to draw the completed repolarization, it's going to be somewhere here. This is going to be the complete repolarization stage. At this point, you're going to get positive current. This positive current means this is going to elevate this baseline, this like baseline point that you're going to see. So if you're going to elevate this baseline point, this is what you're going to get. So which means the entire baseline, the original baseline was basically here, and this injury current has elevated the baseline to a new value, except for the ST segment. And that's why that appears as something called an ST depression. That's all. So that is the reason why, even though the injury current is negative here, in the transmural ischemia, you get an ST elevation. Even though the injury current is positive here, you're getting an ST depression in a subendocardial ischemia. I think somebody else, somebody who has asked this question would have been cleared now. Like, what do you mean by an ST elevation? What do you mean by an ST depression? And how these injury currents are produced, and how you really make up an ST elevation and ST depression in reality. So clear? Everyone understood this? ST elevation and ST depression. So how it happens? Fine. All right. Electrophysiology is most of the time, yes, it's very fascinating. But you really don't need that much of information basically to understand why accept ST segment. Because let us assume, I know somebody should ask this question. Let me take a group of cells again. Where is that? I don't have this thing. Yeah, if you take a group of cells, so what at resting stage? Let us take at resting stage, what will happen? Here there is no copying phenomenon. So at this is at resting stage. At resting stage, you're going to have maybe negative inside. This is normal. And you should have a positive outside, relative positive outside. The cell will be negative. But if you have an ischemia, you are going to get a positive wave. And this is what at resting stage, you are getting an injury current from positive that is moving towards negative. Clear? So this is an injury current that's coming from positive towards negative. Suppose if you're having a completed depolarization, so this resting stage is the one that produces that TP segment and the isoelectric base point. And let us assume a completed depolarization stage. in the completed depolarization stage, you are going to get ST segment. I told you already. Why PR? PR will not get elevated, not get depressed in this particular example. So in completed depolarization state, you are having positive inside completely. Positive inside completely. And you will not have any net current flow. And that's why you're getting an ST segment at this point. And what I'm trying to tell is, because the other cells are also becoming positive and the injured area is already positive and it's getting depolarized, there will be no net current flow here. No net current flow during the ST segment. So during the ST segment, because there is no net current flow and all the areas are supposed to be positive during the completed depolarization phase, the ST segment remains the same at the same level. But because your other areas, entire isoelectric point during the TP segment you're talking about, or a TQ segment you're talking about, if you talk about the ventricles alone, so that things are going to get elevated or depressed because the injury current, which we have discussed already, and that is going to produce an ST depression or an ST elevation. Now that should answer you why ST segment alone is not getting changing. It's the only thing that remains constant at the completed depolarization stage, but all the other areas, the entire baseline is shifting up or down, and it's producing ST elevation or ST depression. So no need to think too much about that anyways, but this is not going to be of that much value really. But anyway, so it will help you in understanding. What is negative and positive current? I think I've explained already through this particular diagram what do you mean by a negative injury current and a positive injury current. Net vector, so see this diagram, man. So you can see this is a lead that is looking at this particular area, and this transmural ischemia produces a current away. So it has to be negative injury current. And of course, this has to be a positive injury current because here the vector is directed towards this electrode, and this has to be a positive injury current. So which is moving towards that particular lead. So there's no doubt about that. Clear? There's no need to ponder on this, leave it, and because it's not really needed that much. So what are the patterns of ischemia? So for example, if you take a STEMI, for example, ST elevation myocardial infarction. So there are certain, I think not everyone is having Ashutosh. Screen and voice are both breaking regularly. I don't think so. Maybe once in half an hour, there will be a 4-second voice break that I've encored already. That is a bug that is there, which I'm trying to fix it. But I don't think every now and then it will happen. And screen, we have not seen. And maybe, your phone should have been updated for some reason. So don't think like that. So I've checked yesterday everything. So it's not a problem. Okay. We have something called STEMI, that is ST elevation myocardial infarction. So what do you mean by an ST elevation myocardial infarction? We have discussed already why it is happening. It's a transmural ischemia, and you have that kind of staging for ST segment elevation myocardial infarction. So stages of ECG changes in ST segment elevation myocardial infarction. So what are the stages? The first stage, we call it as hyperacute stage. So hyperacute stage, during the hyperacute stage, your ECG will be like this. So for comparison, let us draw the baseline ECG like this. So in hyperacute stage, you're going to get this kind of tall T waves. Tall T waves. Let me tell you the definition of tall T waves later on when I'm going to discuss on hyperkalemia. So tall T is what you will get. But still, it's very important to know that the basic understanding is the T waves should be a little asymmetric. Usually I draw basically like that only. Where T wave should never be symmetric like this, like what you see in the classic hand-drawn image. T wave should always be asymmetric, where you should have a rapid upstroke and a little slow downstroke, which means when you take the center of the T wave, it should always remain asymmetric. Even during ischemia, the T waves must always be asymmetric. That's a normal T wave, which we'll be discussing subsequently because we have a whole lot of things to discuss later on. In the entire day, we are going to discuss on ischemic heart disease, myocardial infarction, and ECG only. So tall T waves. So it should be still asymmetric. Suppose if you get a symmetric T wave, even if it is not tall, if you get this kind of a symmetric T wave, that goes towards a hyperkalemia. So everyone would have studied that only tall T waves will produce hyperkalemia. It's not like that. Symmetric T waves are the most important as far as hyperkalemia is concerned. So which is the quintessential feature of an hyperkalemia, even if the T waves are not really tall. So anyways, here still it will be an asymmetric T wave in ischemia, but there will be a hyperacute T wave, a tall T wave. That's what we're going to see in the phase number 1. So why you get a tall T wave? Again, you can think about a hyperkalemia. So let us go back to the, why this is happening. Let us go back to the original ATP section, which you have discussed already. As I told you, once you reduce the activity of sodium potassium ATPase, yes, you are going to produce more sodium inside. At the same time, your potassium is going to increase locally outside. So near the injured tissue or near the ischemic tissue, it's not only the sodium that accumulates inside the cell, it's also the potassium that accumulates outside the cell, near the injured area, near the ischemic area. So which means it's going to produce some sort of a localized hyperkalemia. And that should really explain why you get this kind of a tall T wave. That's due to probably, I mean, we don't know really yet exactly why all these things happen, but probably due to a this kind of localized hyperkalemia is the reason why you get a tall T wave. And then we are going to enter the acute stage. In the acute stage, you will be getting small Q wave formation, and then you will be getting a sort of ST elevation, and maybe plus or minus T wave inversion. So which means a small Q wave. So I can write small like this, plus most importantly, you are going to get ST elevation in this setting. And number 3, you have this kind of subacute stage where your Q waves will progress a little bit and ST elevation will come down a little bit, and you're going to get a T wave inversion. So your Q waves will become prominent, and your ST elevation will be there, but will be less compared to that of the previous stage. Plus, at the same time, you are starting to get T wave inversions also in the subacute stage. Number 4, you get a chronic stage. In the chronic stage, you will be having only the Q waves, small R wave, no ST elevation. T waves are variable. You might have a T wave inversion or upper T wave may be there depending on that. Usually, you will get an upper T wave only. So in this, you will have a Q wave, and that is the most prominent thing, and no ST elevation here. ST elevation would have completely resolved. So why all these changes are happening? To understand this, you need to know why Q waves are produced in the first place. Then we'll see how the Q waves are going to progress. To understand how the Q waves are produced, you have to understand a transmural ischemia was a transmural. In fact, let us assume an area. For example, this area is having a transmural infarction. So now we are not talking about an ischemia. Ischemia will produce an injury current, but infarction is basically a dead myocardium. This area is completely dead and it's not producing any sort of current. So once it's dead for all. It's a scar tissue. It's not going to produce any sort of current, no injury current. If you do not have an injury current, you don't get an ST elevation or probably even a ST depression. You have to be very clear about that. So because it's a dead myocardium, so it creates a sort of an electrical window over here, which means now this lead we are talking about for a long time. So this is now not able to see any current over here. Now once it sees, it's not able to see any current. So it's trying to see beyond that. So normally it cannot see beyond that. For example, if we take a lead here, if the depolarization is happening in this direction, this lead will detect only this current. This lead will be detecting only this current. And it will not be able to detect what is happening on the other side, because there is something called the current that is coming and that is interfering. And that particular current is basically interfering with your ability to see on the other side. It's like a wall. For example, if I'm sitting in this room and if I have a concrete wall, I'm not able to see what is happening on the outside because there is a wall in between that is hiding my vision. Suppose if I remove that wall, if I make that wall die, if I remove that wall and create a window over there, now I can see what's happening on the other side. So in the myocardium, a dead area that is not producing an electrical current is like creating an electrical window, which means now there is no current in this area, which means it is an opportunity for this lead now to see what is happening on the other side. So now on the other side, you know the depolarizations are going to happen in this direction, which means depolarization are going to move from endocardium to epicardium. We know that. So because depolarizations are moving in opposite direction from endocardium to epicardium, you will be really knowing that this will create a negative deflection here, because here you can see the currents are always moving in the opposite direction with this perspective, with this lead's perspective. You see this lead as a standard, and if you see what's happening in the other areas, the current is actually moving away from this particular lead. So they're going to create a negative deflection, and that is what we refer to as a pathological Q wave. And that is the genesis of a pathological Q wave, because it's able to see what's happening on the other side. In the other side, it's moving away from endocardium to epicardium. So that's going to create a negative deflection called as a pathological Q wave. And which means whenever you have a dead myocardium, you're going to get a pathological Q wave. As simple as that. So that is also going to explain why in acute stages you have a small Q, then it progresses, then it becomes very big Q. So why? Because in acute stages, let us assume this is a very acute stage where the myocardium is not completely dead for that matter. So there are a lot of areas of ischemia are there, but in the center there is one area that has gone for infarct. Clear? So which means these ischemic areas, which I've drawn in blue here, will produce injury currents that will produce ST elevation only. Suppose this lead which is present in this particular area, if they wanted to see this area, they will only able to see the injury currents in the form of ST elevation, but a small necrotic area is there in the center that is going to produce a pathological, small Q wave in the initial phase. Later on, if you don't treat them on time, now it's going to, in fact, is going to expand further, worsening the Q wave because it's the sign of a dead myocardium. Now, if the infarct becomes completed, now the entire myocardium is dead. Now you don't really get an ST elevation. You're going to get only the pathological Q wave. So because there is no injury current from now on, if the entire myocardium in that area is dead. So that is the reason why whenever you have an ST elevation, it's usually a sign of myocardial ischemia. So once the ST elevation is lost and Q waves are formed, it's a sign of a dead myocardium. So that's why, you should not wait till the Q waves are formed. You have to treat at the ST elevation stage itself. That is why ST elevation is one of the important reasons why you reperfuse this area immediately. That's why you take the patient immediately for a cath lab, do a PCR, probably you can even do a thrombolysis for these patients. That's really, really important. So these are the 4 stages of a STEMI. So you have first, second, third, and fourth: hyperacute, acute, subacute, chronic. Hyperacute characterized by higher tall T waves that is still asymmetric. Second stage characterized by acute stage, where you have ST elevation as the prominent finding. Small Q waves may be there, may or may not be there. Subacute stages, the most important is the progression of the Q wave with T wave inversion. ST elevation will reduce compared to the previous stage. And in stage 4, you're going to have a chronic stage where there will be no ST elevation, but there will be pathological Q wave. Significant amount of Q wave formation will be there, and there will be no ST elevation in this particular stage. I think whatever I told you till now is clear. So you have understood the stages of a STEMI, and you have understood how ST elevation is produced, how ST segment depression is produced. If it's the case, then we can move on to the localization of a STEMI, because we have known the coronary blood flow. So it's better to localize the STEMI. T-wave inversion. So Indra is asking why you get a T-wave inversion. Remember, T-wave inversion happens due to a different stage. T-wave is a repolarization abnormality. So remember, till now we are seeing that the ST segment is basically happening at the end of depolarization where there's no injury current. No injury current is happening at the ST segment. So that's why ST segment appears elevated or depressed, and the entire baseline is shifted. We studied that. But why really T-wave inversion happens? Because T-wave is a sign of repolarization. We know that it's a ventricular repolarization. In ischemia, as I told you, one more phenomenon is happening. If you see, I think I've described it already. You must be able to comprehend that. So there is reduced activity of ATP sensitive potassium channels, because ATP is needed for this ATP sensitive potassium channels, and there is reduced activity of ATP sensitive potassium channel, means the phase 3 will have a big problem. For example, if we take, this is the action potential and this is the repolarization phase. During the repolarization phase, the potassium should basically go out. Basically, that's what should happen. And what this ATP sensitive potassium channels do is, during the, if the ATP is good, sometimes, they stop the potassium leak. And this is really important during the isoelectric point and all. During the isoelectric point and during the early stages of the, depolarization, this is really important, where this ATP, when it is in excess, they stop the potassium from moving out, and so that the potassium does not leak properly. And that's done by ATP sensitive potassium channels, which block the outflow of potassium. Suppose if you have low ATP, these potassium channels will not work properly, which means the potassium efflux is going to happen at a relatively rapid rate, at a faster rate. That's what is going to happen. If the potassium efflux happens very rapidly, which means I can draw like this, which means the action potential is going to shorten. So I can draw in a much neater way. The action potential is going to happen faster, which means the repolarization will happen much faster in the ischemic areas, because these ATP sensitive potassium channels are no longer working, and more potassium is getting leaked because there is less ATP, and ATP which is less cannot block the potassium movement outside. So the more potassium movement, which happens much early in the course of the action potential, is going to produce something called an early repolarization. As I told you, if you solely take a repolarization, what wave it should generate? Let us take a repolarization. let us take if you take this lead and let us see the repolarization. I mean, you should answer now. Repolarization will happen from epicardium to endocardium or endocardium to epicardium. Repolarization we are talking about. Somebody can answer, isn't it? Epicardium to endocardium, not endocardium to epicardium. Endocardium to epicardium is depolarization. Remember, epicardium to endocardium is repolarization. Clear? So repolarization is opposite. Epicardium to endocardium. We know that. So, for example, in a case of a subendocardial ischemia, let us assume this area is a subendocardial ischemia zone, which I've drawn in red here. And we know in subendocardial ischemic regions, and especially in ischemic regions, there's going to be increased potassium efflux, or you cannot tell increased potassium efflux, early increase in potassium efflux that produces sort of an early repolarization, which means this rule will be broken down. And now the subendocardial region, because it's having rapid and early potassium efflux, they will be the first to repolarize. And repolarization also now will happen from epicardium to endocardium. Clear? So that is the reason why your T wave polarity is reversed. So basically, why you should get a positive T wave in the first place. For that, you need to understand another way. So suppose if you take a lead here, and as far as your notion, if your depolarization moves from endocardium to epicardium, this should create a positive deflection in the form of a QRS complex. Let me draw a QRS complex here. This should produce a positive deflection because this is a depolarization wave moving towards a particular lead. If you take a repolarization wave, basically this should be negative, isn't it? Because it is moving away from a particular lead. But that's where you make it wrong, because depolarization current you can think as positive, which is moving towards the lead, should produce a positive deflection only. But repolarization current, you can imagine like an opposite of depolarization. It's a negative current sort of a thing. So a negative thing moving away from a particular lead still will produce a positive current only. So which means you will get a positive T wave normally in a normal patient. So for example, you can assume that if you have a lot of negative people that are coming towards your life is going to be miserable and your life will be negative only. Your thinking will be negative. If your negative people move away from your life will become positive. So like that, your repolarization wave current that is moving away from epicardium towards the endocardium is going to create a positive T wave only. Suppose on the other hand, in kinds of subendocardial ischemia, we know that because of the rapid potassium efflux and faster movement of potassium outside, yes, almost for the same reason. Left ventricular hypertrophy, the subendocardium will suffer from ischemia because the hypertrophied myocardium will contract much powerfully and they will constrict the vessels more stronger, and the demand also will be more. Subendocardium is more farther also. Compression of the microvasculature is more because the hypertrophied myocardium, so that you will have more ischemia, the subendocardial region. Same reason. And of course, now the like repolarization is going to move. There's an abnormal repolarization that is going to move towards, which means negative people moving towards you. You are going to result in a negative T wave. So T wave inversion is a sign of a subendocardial ischemia. Do you understand? I think this must be clear. That must be it. I don't want to explain more. That's the reason why you get a T wave inversion. Do you understand or not? Yes, right. So you did understand T wave inversion, and you know why you get a upright normal T wave. So then we'll go for the STEMI. STEMI in the sense like we want to localize a STEMI. How will you localize a STEMI? So we know, suppose based on the leads where I have ST elevation, I can localize the STEMI. So based on the leads where I have ST elevation, suppose if I'm going to have ST elevation in probably leads V1 and V2, if I'm going to see ST elevation in these leads, this kind of STEMI will be called as something called as a septal MI. We know that. Suppose if I have ST elevation V3 and V4, this will be called as an anterior MI, because if you take the lead system before, which I have told, V3 and V4 are anterior leads. And if I see elevation V1 to V4, this will be called as anteroseptal MI. Nomenclature is quite simple. And if I get in V5 and V6, plus or minus 1 and AVL, it will be called as an anterolateral MI. So not anterolateral, it will be a lateral MI. It will be a lateral myocardial infarction. Then if you get only in the 1 and AVL, it will be called as high lateral MI, because we know 1 and AVL are high lateral leads. And of course, if you get in V1 to V6 plus 1 and AVL, This will be called as anterolateral MI, or probably you can even call it as an extensive anterior MI or extensive anterior MI. And if you get elevation in 2, 3, and AVF, this is called as an inferior MI or inferior wall MI. And you have two more MIs that you need to know. That is right ventricular MI, and you have a posterior wall MI. And this is a very important pitfall or very important problem with the 12-lead ECG system, because the 12-lead ECG that we have designed is basically going to see the left ventricle only, predominantly. To be honest, whether you believe it or not, it's designed in such a way that it sees the left ventricle properly. It doesn't see the right ventricle properly at all. And at the same time, one problem is it doesn't really see the posterior wall properly. Suppose if you see where the leads are placed, so it's placed on the anterior wall of the chest, and this frontal plane leads also mostly concentrated on the left side. So which means whatever the 12-lead ECG system we are seeing, it's designed to see the left ventricle in and out. They see the inferior wall, they see the like lateral wall, they see a lot of areas, but left ventricle is the one that is seen very properly. But there are other areas which are not seen properly at all. So let us assume right ventricle has a very poor view. For example, only V1 has some view of the right ventricle, but apart from that V1, nothing else has the right ventricular view properly. This is a very important pitfall. And second, posterior wall is not seen properly behind the back. So the posterior wall I'm not seeing with any lead properly. So posterior wall cannot be seen properly. And at the same time, atrium is something which is not seen properly. So which means these three areas are not seen properly at all. Right ventricle, posterior wall, atrium are not seen properly by the 12-lead ECG system. Even in the left ventricle, only the anterior wall, inferior wall, and septal area is seen properly. It's okay. With the 12-lead ECG is very good in seeing these areas. But the other areas, even with the left ventricle, the posterior wall is not seen properly at all. So that is why we need to have some specialized leads. So this view is very poor with the 12-lead ECG. So that is why we need some specialized leads to look at these areas. For example, to look at atrium, it's really difficult to look at what is really happening in the atrium. But if you want to really look in the atrium, the best way to look for the atrium, even though we don't do this, is esophageal leads. So actually, esophagus gives the best view for the atrium, especially the left atrium is concerned. That is why if you want to see the atrium properly, in echo also, you go for transesophageal echo. That's the best view to see the atrium. And leads also, of course, it's going to be esophageal ECG leads, but really we don't do that. But the best gold standard is, of course, going to be the esophageal leads. If you want to see the posterior wall, the best lead system will be the posterior leads, which means you have to modify the existing system and you have to create a new lead called a posterior leads. This is going to be the best. So what we do really, so we have V1, V2, V3, V4, V5, V6 over here. So what I'm going to do is I'm going to remove the V1, V2, and V3, and I'm just going to place in the same fifth intercostal space on the back. For example, I'm going to keep in the posterior axillary line because till V6 will end in the mid axillary line. Then I'm removing V1, V2, and V3. I'm placing on the back posterior. So now V7 will be placed in the posterior axillary line. V8 will be placed in between the V7 and V9, and V9 will be placed in the paraspinal region in the same fifth intercostal space. I'm going to extend it on the back, which means I'm just modulating the existing 12-lead ECG system, which means posterior leads are nothing but V7, V8, and V9, which are nothing but V1, V2, V3, which have changed the position and I've kept on the back. That's all. Now it will be called by a new name. Now, if you take about the right ventricle to an extent can be seen by V1, but still it is very poor. It's not very good. But if you want to have the best view of the right ventricle, then you need to have the right-sided leads. Right-sided leads that will have the best view for the right ventricle. So typically speaking, what we are going to do is we are going to reverse the lead system. For example, you know V1, V2, V3, V4, V5, V6 on the left side. Now just flip it and produce V1R, V2R, V3R, V4R, V5R, V6R. Just put it on the right side. ST depression would be seen on the corresponding leads. Wait. We are not yet discussed on the reciprocal changes. So let us take step by step. Medicine is like smooth and steady. It should be like brick by brick. Step by step we have to go. It's not like suddenly we have to tell everything at once. So you are going to just reverse it and produce on the right side. So it's V1R, V2R, V3R, V4R, V5R, V6R. V4R will be placed somewhere here, and that V4R on the right side, which means it's the same leads only, but I'm flipping the orientation to the right side, and that will be the best view for the right ventricle is concerned. Suppose if you want to see the right ventricle in a best way, V4R will be the best to see the right ventricle. So these are the best leads, to be honest. So if they ask you the pitfalls of the 12-lead ECG system, posterior wall right ventricle atrium is not seen properly as expected. Atrium best is esophageal leads, posterior wall best is posterior leads, right ventricle best is the right ventricular leads, especially the V4R. That's going to be the most important, really, really important. I think that must settle the issue. So which means if I see the ST elevation in V7, V8 and V9, if I see the ST elevation in V4R, that will be suggestive of right ventricular MI. If I see ST elevation V7, V8 and V9, that will be suggestive of a posterior wall MI. As simple as that. So this is the posterior lead, this is the right sided lead. That's going to be the gold standard for detecting the right ventricular MI and posterior wall MI. So accordingly, I can tell the culprit lesion also. And more importantly, there is something called a reciprocal, because Riju was keeping on telling about the reciprocal ST depression. So if a particular lead, for example, if my anterior leads are seeing it as ST elevation, the opposite, so ST elevation, the opposite leads, because injury current is different there, they're going to see it as ST depression. Or on the other hand, you can assume that we have seen that this particular lead is seeing, this injury current is producing the entire baseline down. So you're seeing ST elevation here in this area. On the other hand, if you see in an inferior lead, for example, in a lead 2 or lead 3 or lead AVF, which is nothing but an inferior lead, in this area, the negative current is actually moving towards, the negative current is basically moving towards this. So they are going to actually, do something else. They are just going to push the thing down. So that is going to do something called a ST depression here. So you're going to get something called a reciprocal ST depression. It's completely opposite. You're going to get a reciprocal ST depression. Clear? They're going to shift the isoelectric baseline in a different area. So this is a reciprocal ST depression. It is completely opposite what you tend to see. So you can imagine, like, if one set of leads in a particular view are seeing ST elevation, the other set of leads are going to show something called an ST depression. That's quite simple. So that is what we mean as something called reciprocal ST depression. And this is really, really important as far as STEMI is concerned, because based on that only you are going to localize the culprit vessel with the STEMI. So fine. So now you have ST elevation and a reciprocal ST depression. That is a characteristic feature of a STEMI. If one set of leads show ST elevation, the opposite set of leads, which is seeing in a different direction, might show ST depression, which is nothing but a reciprocal change. That's all. This ST elevation in this lead will be seen in that lead as an ST depression because it's seeing in a different direction. Okay. So how to localize the culprit artery? Now you know that the blood flow. So what are the areas that are supplied? So now how to localize the culprit vessel? So which artery? So ECG is also referred to as something called a poor man's angiogram, which means with the ECG itself, you can predict to an extent that what vessel will be affected. So it's like a poor man's angiogram. So how can you tell what is the culprit artery? So we know that there are certain things for sure. If you have a right ventricular MI, the reciprocal change is nothing but man. So no need to confuse too much. So this, again, it will waste a little bit of time. So that is not really needed. Reciprocal changes means if one set of leads are seeing ST elevation, the other set of leads, of course, they are going to show ST depression. That's all. So nothing else. That's what we're going to see. Clear? When to suspect need for right or posterior wall MI? I mean, we are going to discuss that only. So no need to worry about the one set of leads showing ST elevation, other sets of leads showing ST elevation, which I think from a different direction. For example, if I'm moving the right hand here, so some people, if they're seeing from a different direction, they might see it as my left hand, if it's my mirror image. So it's like in what orientation they see, that's all, nothing else. So let us assume the culprit artery now. So what is going to be the culprit artery? So that's really important. So, I mean, you should not know a lot of things, but still you should know something in this. So for example, if the patient is having probably inferior wall ST elevation, I mean, for example, if I'm seeing the patient is having inferior wall MI. So inferior wall MI has a lot of ideas. So for example, inferior wall can be supplied by right coronary artery. Inferior wall can be supplied by left circumflex also, depending on which is dominant, because inferior wall is basically supplied by the PDA. Depending on where the PDA is originating from, either from the RC or LCX, you might have the culprit artery. How to find out whether which is the culprit artery here? So we have a simple notion for that. So you need to see the V1 typically. If the V1 is showing elevation, that is suggestive of a right ventricular MI. We know that. So let us draw the leads again so that to understand this better. So for example, right ventricle here, left ventricle here. RCA typically is going to produce right. Suppose if RCA is the culprit, it will usually produce a right ventricular infarction and probably an inferior wall infarction as well. So RCA is something going to produce an RV or probably a inferior wall infarction if PDA is coming from the right coronary artery. So how will you identify that? So now you can see this lead 3 is here and lead AVL is here. So let us take these two. Lead AVL is here, lead 1 is here, and lead AVL is the one that is exactly opposite to that of 1. Suppose if there is an inferior wall MI, so it is going to produce, suppose if it's a right coronary artery involvement, so your injury is going to be more on the right side. So the injury current will be more on the right side because the right coronary artery that is involved. It's going to produce more on the right side areas. Right side is the one that's going to be injured more. The injury current is going to be more on the right side. Clear? So how to find out which is primary and which is reciprocal? I mean, you think ST elevation will be reciprocal? ST elevation is always primary. The ST depressions is reciprocal. That settles your question. How can it be? Like, how can you take ST elevation as a reciprocal? If you take ST depression as primary, you think ST elevation will happen as a reciprocal change? There can be reciprocal ST depression, but there can't be reciprocal ST elevation. Clear? So usually. So that's an injury current that's moving on. So clear? So that's towards the right side. So which means the ST elevation that are going to get on 3 is going to be more. And because the injury current is more oriented towards this particular direction, the ST depression on AVL is going to be more compared to the other leads. So the ST depression on lead AVL will be maximum compared to all the leads, and ST elevation on lead 3 among all will be maximum. That's the idea. Suppose inferior wall MI means I'll be seeing ST elevation leads 2, 3, and AVF, and reciprocal changes may be seen in 1 and AVL. So if at all I'm seeing ST elevation in lead 3 more than lead 2, I can conclude that this patient is probably having a right coronary artery involvement, very likely. And suppose if my reciprocal ST depression is more in AVL compared to that of lead 1, so I can conclude that this patient is once again having a RCA involvement, right coronary artery involvement, because the vector is more towards the right side. That can happen only with the right coronary artery. And at the same time, if I'm seeing ST elevation in V4R, that's straightforward. ST elevation V4R. ST elevation V4R is equal to RCA involvement only. Because why it's equal to RCA? Because V4R elevation means it's a right ventricular MI. Right ventricular MI, if you prove there can be only one, artery that can supply the right ventricle, that is the right coronary artery. So suppose if at all you have ST elevation V4R, 100% it confirms it's a right coronary artery only. Or if at all you have an ST elevation in V1. So I told you V1 is the only lead that supplies the right, that sees the right ventricle to an extent. Suppose if you have a RVMI, and if with an inferior MI you are having a V1 elevation, that definitely suggests there is an associated right ventricular MI. So once again, it tells you it's a RCA involvement. So whenever you talk about RCA involvement, look at V1, look at V4R, look at 2, 3 AVF, which is more showing more elevation. Look at 1 and AVL, which is showing more depression. So ST elevation more than 3, more than 2, then it's likely to be RCA. AVL, more depression. Even posterior wall show maximum elevation V4R. Posterior wall MI, elevation V4R. Posterior wall is here, V4R is here. How it can show elevation in V4R? Right ventricular MI only will show elevation in V4R. Posterior wall MI will show elevation in V7, V8, V9 only. How they will show elevation in V4R? V4R will not show any elevation in posterior MI. V4R is a lead that is designed for the right ventricle, not for the posterior wall. Did I write before like that? No, I've written V4R is right ventricular MI. V7, V8, V9 is for posterior wall MI. No. I don't know. Maybe I would have write and I would change probably. I don't know. Maybe you would not have noticed in between. But anyways, I wrote that only. So V4R means it's right ventricle and posterior wall. I mean, let us come back to that. So let us analyze step by step. Now you know how to analyze RCA. RCA can produce a posterior MA. Remember, it's not like RCA cannot produce a posterior MA, right? I mean, what your question, Ranak Bir, is correct. See, V1 is the only lead that sees the right ventricle, man. V1 is the only lead that sees the right ventricle to an extent. If you have a V1, like elevation, which means there is a right ventricle involvement. Right ventricle is supplied only by RCA, we know that, and that must be equal to RCA involvement. That's all. So this is a simple rule whenever you see this kind of stuff. And your problem will arise. So whenever you have a right ventricular MI, there is no problem. But the problem will arise only when there is a posterior MI. So let us see how you will get a LCX involvement. So what LCX can do? LCX typically tends to involve the lateral wall very commonly, and probably posterior wall to an extent, and rarely inferior wall also. Clear? RCA can also involve the inferior wall, I mean posterior wall, which we'll be discussing subsequently. So let me draw the posterior wall separately here. RCA can also involve the posterior wall, but LCX can also involve the posterior wall, but most often posterior wall involvement will be due to LCX only, left circumflex. We'll see how can you understand all this. So lateral, it can involve the posterior wall, it can involve the inferior wall. So currently we are talking about inferior wall MI only. So since we are talking about inferior MI, let us restrict our discussion with the inferior MI. So suppose if LCX, left circumflex, is causing inferior MI, because now it's a left dominant system. I mean, don't worry about that. So now we have crossed the ST elevation, Dr. D, and no need to unnecessarily confuse this. Let me I mean, at the end of the time when I'm going to discuss these, you will be easily understanding this. Anyway, so left circumflex is going to have an inferior wall MI. I mean, if it's causing inferior MI, so what will be the characteristic features? So since it's a left circumflex producing the issue, so of course your vector will be directed towards the left side only, at least to an extent. It will not be towards the right side, which means, of course, you know, this is lead 3 and this is lead 2. And of course, you know, if you get an ST elevation, and inferior MI is going to have 2-3 AVF elevation. And of course, if it's an ST elevation, your lead 2 will be more than lead 3. That's the first point that you need to know. If it's an LCX involvement, which is opposite for RCA, lead 3 will be having more ST elevation than lead 2. And if you talk ST depression, you don't really have ST depression. 1 and AVL will not have any ST depression, no ST elevation in the first place. 1 and AVL will not have any ST depression. In fact, in 1 and AVL, you will get no ST depression, which means in 1 and AVL, your ST segment will be either isoelectric, or probably you can even show an ST elevation if your lateral wall is involved. If lateral wall is significantly involved, then you might even get an ST elevation. So what you got in RCA involvement is actually ST depression in AVL and 1, where AVL depression will be more than 1, whereas in this kind of left circumflex related inferior MI, your ST depression will not be there in 1 and AVL. In fact, there will be ST elevation or a isoelectric ST segment. So this is how you are going to diagnose circumflex involvement in inferior MI. Suppose if you take the V4R, suppose if you're having a doubt that inferior MI may be associated with the right ventricular MI. So what you will see in a V4R, suppose if it's an LCX involvement. If it's an LCX causing like your inferior MI, then definitely there won't be right ventricular involvement. 100%. How LCX can supply right ventricle? It cannot supply right ventricle. So the vector will be towards this side only. It will not be towards the right side. So of course, V4R is a lead that is going to be placed on this area. So which means this vector is moving away from V4R, and V4R will typically show ST depression only. V4R will show ST depression. So inferior MI with V4R showing ST depression, you can think about LCX involvement. That's all, as simple as that. So clear? So let us summarize. So what all we have seen? Inferior MI is usually due to PDA ischemia. PDA ischemia can happen due to RC involvement or can be due to circumflex involvement. So ST elevation 3 more than 2, 3 more than 2, and ST depression in AVL more than 1, and V4R I mean, these are associated things, plus or minus P4R if you have ST elevation, and plus or minus in V1 if you have ST elevation. All that concludes surely it's a right coronary artery involvement only. If it's a left circumflex, then you will see ST elevation in typically, I mean, in 2 more than 3, not in 3 more than 2. We are talking about inferior MI alone here. And if you have an ST depression, I mean, you will not, it will be either flat or elevated in 1 and AVL. I told you. Plus or minus V4R will show ST depression only. Plus or minus V1 also will show ST depression only. So this is how you predict this probably a left circumflex involvement. It is not a RCA involvement. So now we are clear about the inferior MI. Inferior MI can be due to RCA or LCX. So these are the findings that will tell you which is the artery that is involved, RCA or probably a left circumflex. Now we are moving towards something called anterior MI. Anterior MI. Anterior MI. Anterior MI means you know very well. You can get anywhere from V1 to V6. From anywhere from V1 to V6, if you get elevation, that's an anterior MI. So whenever you have an anterior MI, so there can be only 2 possibilities basically. One is either a proximal LAD or it could be a distal LAD, which means whenever you see an anterior MI, it must be left antidescending artery only, as simple as that. So it can be either LAD or it could be LAD, distal left antidescending artery. So how will you find out whether it's a proximal LAD or a distal LAD? Idea is very simple. So let us take a septum here. Let me draw like this. Septum and the ventricular walls. I don't know. I don't have a duplication option here. So that's a big problem. This is a septum here. So suppose if I want to involve the ventricle in a proximal LAD, there's going to be a huge area that will be involved as far as proximal portion is concerned. So proximal LAD is concerned. This is where the typical area of involvement of the proximal LAD. So you can see that the vector is basically directed like this because most of the bulk of the myocardium is involved here. So the vector will be basically directed in this area. The injury current will be in this particular direction because there is so much area that is involved. Point number 1. When you occlude a distal LAD, so it will be somewhere here. This is a portion that will be involved in distal LAD, which means a small portion of the septum and little bit of inferior wall. Because LAD, small extent, they'll supply the inferior wall. I mean, depends on how much it wraps around the inferior wall, they can supply a lot of amounts of inferior wall also. So that's not my problem. So, but here, if you see, the injury current will be basically directed downwards. Not really downwards, but a little like this. Little left towards like this. So this is how the injury current is going to be. So first thing that I want to see is the 2-3 AVF. You might wonder why I want to see the 2-3 AVF, because even though V1 to V6 elevation is there, my 2-3 AVF is going to give a very good idea about whether it's a proximal LAD or a distal LAD. Suppose if I'm having, if I'm seeing 2-3 AVF, what will happen in 2-3 AVF? They are seeing from the lower part, inferior view. So in this particular section, if the injury current is moving in this area, that is producing the ST elevation. If my 2-3 AVF is seeing a current that is moving away from it, so 2-3 AVF is going to show ST depression. So whenever my 2-3 AVF is showing ST depression, I can assume that it's a proximal occlusion. Suppose if you draw the vector, in vector it's very simple. Whenever a vector is going like this, you have to extrapolate and draw like this perpendicularly. So some like this, some force will be like this. So since both the forces are going in 2 different directions, you are having a net vector in this particular direction. So which means there will be some force exerted in this area also, some force exerted in this area also. So of course, V1 and chest leads and all these things are going to show elevation. There is no doubt about that. And contrary to the belief that there's an inferior MI here, it's not an inferior MI, but still 2-3 AVF, because some of the vector is pointed towards the inferior direction, you can get a small amount of ST elevation in the inferior leads also. This is something very difficult to understand, at the same time, very difficult to even logically think. Students might think that suppose if I'm seeing in V1 to V6 and 2-3 AVF, I'm seeing ST depression, you call it as an extensive anterior MI, all right. But I'm seeing elevation in V1 to V6 somewhere, plus I'm seeing in 2-3 and AVF elevation. This is not an extensive anterior MI. In fact, it's a distal LAD lesion. It's a small MI only. So, but this is one of the logical pitfalls of the ECG, and sometimes, at least to the beginners, because when you see V1 to V6, 2, 3 AVF elevation, you'll be thinking that you are seeing a very big MI. In fact, it's affecting the inferior wall, it's affecting the anterior wall also, but very often it will be a distal AD lesion because of the vector distribution, which I've shown here. Sometimes your elevations may be there in anterior as well as inferior leads. It doesn't really mean it's a huge MI, even though the vector distribution tells that it must be a huge area of myocardium that is involved and it is ischemic, but typically not. So that's one thing that is has to be known here. So it doesn't mean that's a huge MI, that is just a distal AD lesion. But if you see only in V1 to V6, it's a proximal AD lesion. So, and if you see 2, 3 AVF, not an important MCQ, but you can get an ECG. That's why. Yes. So distal LAD or probably a wraparound LAD. No, it's not difficult to pick up in exam. I'll tell you how to pick up. I'm going to show the ECGs in some time. It's very easy to pick up. So wraparound LAD also can do the same thing, but this is not something I like it. Wraparound LAD is not a very common sensical thing if you see in angiogram and all, but distal LAD lesions commonly tend to produce 2, 3 AVF. Wraparound, I mean, can produce a similar picture, antero-inferior kind of an elevation, but not really. But how you can see that wraparound LAD is, usually you can compare the V1 to V6 versus 2, 3 AVF ST elevation. In V1 to V6, you will have so much of ST elevation. Same amount of ST elevation if you see in 2, 3 AVF also, you can probably think about a wraparound LAD. But if you don't see that much elevation, if you see only like 3, 4 millimeter elevation in both V1 to V6 and even lesser elevation in 2, 3 AVF, then you can think about probably a distal lesion. Remember, distal LAD lesion is far more common than a wraparound LAD. Wraparound LAD, you have 3 different types of wraparound LAD. Only in type 3 wraparound LAD, I mean, that will become more complicated if I keep on telling. That will cause a typical inferior MI. If wraparound LAD usually will be type 1 or type 2 only, that will not really cause that much amount of inferior wall involvement. So whenever you have a inferior wall ST elevation, think about a distal LAD lesion. That's the idea. So now you know how to diagnose anterior wall MI. But you have different vessels, isn't it? So for example, if you take LAD, let me draw only the LAD, leave the circumflex now. If you take the LAD, this is the LMCA, this is the circumflex, this is the LAD. So as far as the LAD is concerned, you know, they are going to produce septal branches. This is the first septal branch. That's the most important. That supplies the septum. That's called the basal septum. Remember, this is the base of the heart. This is the apex of the heart. So basal septum. And these are diagonal branches that are supplying the anterior wall. So let me draw the first diagonal branch. So this is the D1. These are the important branches. So S1 is the first, D1 is the next that comes from. Suppose if it's a very proximal, that is very proximal to, you know, like proximal to S1 branch. So what really happens is the myocardium will be injured mostly in the basal area and the basal septum. And of course, you are going to have involvement in the other areas also, but basal septum will be involved. This will actually make the injury vector go somewhere towards this particular area. So which means if this basal septum is involved, you will typically see AVR elevation. Suppose whenever you see AVR elevation, you think about very proximal lesion, especially proximal to the S1. So proximal to S1 lesions typically will have AVR elevation. And at the same time, they will be having right bundle branch block most of the times. If you have RBB or probably if you have a AVR elevation, think about a proximal to S1 branch involvement. Suppose if it's proximal to D1, and but distal to S1. So it's distal to S1, but proximal to D1 in the sense you will have a kind of this kind of a proximality kind of lesion. You will not really be having right bundle branch block and AVR elevation. That's the only idea. Apart from that, nothing else you need to know. So proximal to S1, how will you find out? If you have AVR elevation and right bundle branch block, that's a sure shot sign that this patient is having a very proximal. It's a very severe disease. It's a proximal LAD involvement, proximal to S1 branch. That's a more severe kind of a myocardial infarction, to be precise. And now let us discuss on lateral wall infarctions. So what is a culprit artery if you are encountering a lateral wall? Lateral wall MI. So lateral wall MI can be due to many factors. It can be due to left circumflex very commonly, or it can be due to LAD, especially the D1 branch. The diagonal branch sometimes can be very big so that it can go and supply the lateral wall also. But this is the most common realistic scenario. So how will you know it's a lateral wall MI due to LCX? Usually whenever LCX is involved, it will be having associated elevations in V5, V6, 1 AVL everywhere. So this is what typical L6 slated lateral MI will produce. Whereas whenever LAD D1 branch is affected, and because of that you get a lateral MI, mostly your elevations will be restricted to 1 and AVL only. You will usually won't see V5 and V6 ST elevation. If you don't see there, typically it goes towards a LAD D1 occlusion, which we'll be discussing subsequently over a period of time. And post-level MI. Of course, how will you find out post-level MI? It's very simple. Post-level MI can be due to LCX involvement or can be due to RCA involvement. And post-level MI many times will be associated with inferior MI because both RCA and LCX both supply the inferior MI. So that's a big clue. Many times post-level MI will be associated with inferior MI. But whenever it's associated with inferior MI, it more goes towards a left circumflex compared to that of the RCA. That's something that has to be known. So how will you find out post-level MI? So you know how to find out RCX versus LCX versus RCA. Only with isolated post-level MI, you cannot really find out. Suppose if you have an isolated post-level MI, it's not possible to find out whether it's LCX or RCA. But you can really tell in the ECG, how will you find out the post-level MI? In the post-level MI, gold standard, to find out a post-level MI, gold standard is always going to be the posterior leads. That is V7, V8 and V9. That's all. But you can find out in the standard 12 lead ECG itself. If you want to know how to find out in the standard 12 lead ECG, you have to know something called a mirror image pattern. So if you take V7, V8 and V9, the exact mirror image that is opposite, D1 occlusion, obtuse marginal are almost the same. There is no difference. I'll come back to that. Obtuse marginal also will show similar changes. V5, V6, 1 and AVL only. Main LCX occlusion also will show V5, V6, 1 and AVL only. Only if you see in 1 and AVL, very high lateral, then you can think about a D1 involvement. That's all. So anyway, so come back to the 12 lead ECG. So posterior leads are here on the back and anterior leads are here, V1, V2, which means this V1 and V2 is exactly opposite to what you see in V7, V8 and V9. Suppose let us see what happens in V7, V8, V9. V7, V8, V9, you might be seeing ST elevation let me draw full picture. V7, V8 and V9 can show a Q wave, ST elevation, and a T wave inversion. So this is a completely evolved MI. So this exact mirror image is what you're going to see in standard 12 lead ECG in V1, V2 probably. In V1, V2, this Q wave, now it's going to get flipped to become an R wave. So let me draw the P wave here. So P wave will be the same. This Q wave is going to get flipped as R wave in V1, V2. And this section of ST elevation will become an ST depression. And this T wave inversion will become an upright T wave. So this is what you're going to see in the V1, V2, a same mirror image concept as reciprocal leads. So which means in V1, V2, if you see a prominent R wave with ST depression and an upright T wave, it is almost certain in a patient with a chest pain that is suggestive of a post-level MI. So what is the gold standard? In V1, V2, generally normal fact is you will see something like this only. Sorry. Normally you will see something like this in V1 and V2. Let me come back to that. Normally you will see something like this. So this is normal. So this is normal where you'll see a small r and a big S. But if whenever you see a big R, small s, something like this, so this is RS. So which means normally RS ratio will be less than 1, which means R will always be small in V1. That is normal. Suppose if you see a bigger R wave, so which means RS ratio more than 1, which means this is clearly abnormal. And in a patient with a chest pain, that is equal to post-level MI. That's all. Any patient with a chest pain having an RS ratio of more than 1 in V1, V2 with a ST depression with an upright T wave is equal to post-level MI. So you can easily pick up post-level MI in a standard 12 lead ECG itself, but even though the gold standard is of course going to be the V7, V8 and V9. Yeah, I'm talking about a chest pain here. In an ischemia case, in a chest pain. So that we are talking about. You're not talking about, and there are a lot of other conditions which can produce R wave more than S wave. Remember, R wave bigger than S wave can happen in right bundle branch block itself. We're not talking about that. So you're talking about once you rule out all those causes in a patient with a chest pain is equal to post-level MI. Why R wave is taller in ischemia? I told you, isn't it already? It's a mirror image. Because of the mirror image, this Q wave is the one that is looking as an R wave here. That's a mirror image. That's what you're seeing there. So whenever you see that kind of a mirror image causing bigger R wave, RS ratio more than 1, it's clearly abnormal in a patient with chest pain. We always take it as a posterior wall MI unless proved otherwise. So this is really, really important. So once we see the ECGs, you will be understanding much better, because this is only theory which I'm telling. Practically, this is easy to understand. So if you want to know a significant ST elevation, so what do you mean by significant ST elevation, and when will you diagnose it as significant ST elevation? There is a rule for that to tell it's a significant ST elevation. Remember, at least more than 1 millimeter ST elevation, more than 1 millimeter ST elevation, 1 millimeter ST elevation in at least more than 2 anatomically contiguous leads. Now you will be knowing the idea of what you mean by contiguous leads. Inferior leads are contiguous, lateral leads are contiguous, anterior leads are contiguous, septal leads are contiguous. So you know what you mean by contiguous leads. At least 2 continuous or anatomically contiguous leads should be involved. At least more than 1 millimeter ST elevation should be seen. And there is an exception to the rule. Exception comes in the form of V2 and V3. And exception comes in the form of right and the posterior leads. Right leads means you know it's V4R. Posterior leads you know it is V7, V8 and V9. So in V2 and V3, you require more than 1 millimeter, which means 1 millimeter is not enough. Normally itself in V1, you will be having more ST elevation. A normal small ST elevation is common in V2 and V3. So in V2 and V3, if it's a female, you keep a cutoff of more than 1.5 millimeter. It's not 1 millimeter. If it's a male, suppose if age less than 40 years, you're going to keep a cutoff of more than 2.5 millimeter. And if it's age more than 40 years, you're going to keep a cutoff of more than 2 millimeter, which is very, very important. This is a very important exception given in ACCHA guidelines, where the ST elevation must be different in V2 and V3, and the cutoff is little higher for ST elevation. And for right and posterior leads, because they are extremely sensitive, the cutoff is lower. It's not 1 millimeter, it's less than 1 millimeter, just more than 0.5 millimeter is enough for right and posterior leads. For V4R and V7, V8 and V9, just 0.5 millimeter is enough. 0.5 millimeter ST elevation is more than enough. This is what we refer to as something called a significant ST elevation. So then we have a ST depression, significant ST depression. I'll show all the images, don't worry about that. So when you call it a significant ST depression, especially when it is more than 0.5 millimeter, that will be called as an ST depression. So in any lead, if it's more than 0.5 millimeter, it will be called as an ST depression. And the biggest question is, where will you calculate the ST depression, where will you calculate ST elevation? For example, if you have an ST elevation all right, and you have an depression all right, ST depression all right, where will you calculate, which point? This you will tell ST elevation, or this you will tell, where will you calculate the ST elevation? What point? So we know this is the J point. So this J point is the point where, like your ST segment and the QRS complex meets basically. So to find out ST elevation, you have to take a point that is 80 milliseconds from the J point. 80 milliseconds from the J point. Or if you want to diagnose ST depression, you have to take a point at 80 milliseconds from the J point. From the J point. That is the area where you have to see for the ST elevation and ST depression. That's the site where you have to calculate the ST elevation, and that's the site where you have to calculate the ST depression also. So it's 80 milliseconds from the J point. This could be a problem and a potential question. And suppose if the heart rate is very high, more than 130, in that setting, you can keep a cutoff of 60 milliseconds from the J point for both ST elevation and ST depression. Because in higher heart rate, the cardiac cycle will become shorter. So it's not good to take 80 milliseconds where you'll go out of the T wave in some time. So that's why they're given a 60 millisecond cutoff if the heart rate is more than 130. If the heart rate is less than 130, for all practical purposes, you have to calculate ST elevation from 80 milliseconds from the J point, or 80 milliseconds means 2 small boxes from the J point. That's the point where you have to calculate. I mean, these are criteria and rules, so which you'll be very familiar about, which you have to be very familiar about, because these are the areas that you will commonly get tested in exam. So now, whatever the understanding we have given, the culprit artery and the significance of ST elevation, let us go back and see some of the ECGs and understand whether you understand or not, to know it better. So this image will show a good understanding about what's really happening. So what is a lateral wall problem? What is an anterior wall problem? What is anterolateral? What is anterior wall? What is inferior wall? So different areas of the left ventricle is given here, where you can see this is the anterior wall we are talking about. This is the septal wall we are talking about. This is the inferior wall we are talking about, and this is the lateral we are talking about. Even though the posterior wall is not given, it must be somewhere over here. Clear? And let me talk about different types of myocardial infarction now. So these are the sequence of ECG changes. As far as sequence of ECG changes concerned, you can see this is ST elevation point, and this is a Q wave formation, and ST elevation is still there, that is depressed, and hyperacute is not given here, sorry for that. And then ST elevation will further depress, Q wave will become even more bigger, and your T invasion will become even more like deeper. And here you have only Q wave, no ST elevation, and the T wave has become normal. So this kind of only Q wave is a sign of an old myocardial infarction, because here, why you called old myocardial infarction? Here there is no salvageable myocardium, which means there is no myocardium that is alive. All the myocardium has been dead and it's not salvageable. That's why we come to a conclusion that this must be a old myocardial infarction. Then let us see this one. So this is an example of a hyperacute stage of an MI, where you're really seeing this kind of tall T waves. This is an hyperacute myocardial infarction. Hyperacute myocardial infarction. So multiple leads, you are able to see this kind of tall T waves. In V2, you're seeing tall T, V3, you're seeing tall T, and in many areas. And reciprocal depressions are also, other areas are also there. For example, you can see this kind of deeper T wave inversions here. Fine, so that's not an issue. Leave that. But more importantly, what I'm about to see is some PVCs also there. I'll tell you what are the premature ventricular complexes later on, but that is not important here. So this is just to show that this is an example of a hyperacute myocardial infarction which shows tall T waves. Then as far as the next image is concerned, so you're going to tell the culprit artery now. So what is the MI you're seeing here? What is the MI you're seeing here? You want me to show where are the ST elevation, or you will diagnose by yourself? Let us be interactive. So this is going to be fun. You can answer, guys. It's very simple. Yes, it's quite simple. So you are seeing ST elevation in 2, 3, and AVF. This is the principal site of ST elevation here. So 2, 3, AVF. You're seeing ST elevation. Let me show ST elevation here, ST elevation here, and ST elevation here in AVF. So definitely there is some inferior MI going on. There's no doubt about that. If you're having an inferior MI, then next step is to see where is the localization. It could be either RCA, it could be either RCA, or it could be LCX. To find out the culprit artery, you need to see the lead 2 and lead 3. So where the ST elevation is more, lead 2 is more than lead 3 is more than lead 2, or lead 2 more than lead 3. So it's very clear in this example that lead 3 is showing more elevation than lead 2. That tells you that this patient is having an RCA involvement. And at the same time, if you see the ST depression in 1 and AVL, you do have ST depression in 1 and AVL. And I'm seeing that ST depression in 1 and AVL comparatively, AVL is showing more ST depression compared to 1. If you see, this is showing a deeper ST depression compared to the 1. So definitely it must be an RCA involvement. But more than that, there is another clue for this. I'm seeing elevation in V1, basically. So V1 also. V2, V3, V4 can be seen because it's little closer to the right ventricle. So that's not an issue. My idea is to see only for the V1. So V1 is also showing, but V5, V6 and all is normal. So V5 and V6, I'm not really seeing much ST elevation. So V1 is showing ST elevation. So this is likely to be a, like right ventricular myocardial infarction. So this patient is having inferior MI along with right ventricular myocardial infarction. This clearly tells this is not LCX involvement. This culprit lesion is going to be in the right coronary artery only. So this is an RCA involvement. So this must be usually a very proximal RCA, because if they are producing right ventricular involvement, means they are affecting the acute marginal branches also, which must be a very proximal RCA. Now let us see this one. So what is this one? Is there any MI here? If there is any MI, you are going to tell what is the MI that is seen. What is the culprit artery and how it is localized. What is the culprit artery here? And what is the MI here, first of all? they are showing hyperacute T waves. Yes, these are hyperacute T waves only, but there is some ST elevation is still there. So you are seeing in 2, 3, and AVF. Of course, you are seeing. So it must be an inferior MI for sure. So not seeing much elevation in the anterior wall. So it must be an inferior wall MI. So it can be either from RCA or maybe from LCX. So, but what I am able to see in this particular ECG is that the elevation in 3 is comparatively more. So if we take this the J point, and if we take some 40 milliseconds, the elevation in 3 is relatively more compared to that of the 2. So ST elevation in 3 more than 2. So that must be basically an RCA involvement. But to confirm that, I can also see the AVL and lead 1 involvement. So depression AVL is more than 1. So that clearly tells you it must be an RCA. But as far as I am seeing V1 is not showing any ST depression. So it can be right ventricular MI, but this, as far as the 12 lead ECG is concerned, I'm not seeing any right ventricular MI, which means it must be probably a distal RCA involvement. So where the acute marginal branches are spared, only the inferior wall and the particular inferior wall is involved. And it must be an RCA because of these particular changes, and it's not an LCX for sure. Fine. Then what about this one? We have seen this, yeah. What is this one? What about this one? So of course it's a STEMI. I'm talking about a STEMI only. Sorry, I'm talking about a STEMI only. And what is the type of STEMI here? Let us understand step by step. It's an anterior wall MI only for sure. So V1, I don't really see much elevation. V2, yes, there is an elevation. V3, yes, there is an elevation. And V4, yes, there is an elevation. And V5, yes, there is an elevation. V6, yes, there is an elevation. But more importantly, one biggest clue for ST elevation, one biggest clue for ST elevation, I mean, for a STEMI is the fact that you have a Q wave here. You are already formed a lot of pathological Q waves. So whenever you have this kind of pathological Q waves, this is typically suggestive of a, like STEMI only. So this is quintessential feature of a STEMI. So you have a Q wave with an ST elevation means there is no doubt about that. This must be STEMI for sure. And apart from that, if you want to really localize where it is found, so let us assume somewhere around V1 to V6, you're seeing ST elevation. So which must be LAD only. So it cannot be something else. So if it's LAD, then you have to see whether it is proximal or distal. So how will you know whether it's proximal or distal? See 2, 3 AVF. So 2, I don't see any ST elevation. 3, in fact, I'm seeing ST depression. AVF, in fact, I'm seeing ST depression. So it must be a proximal LAD. So it may not be a distal LAD. It must be a proximal LAD. And if it's a proximal LAD, then I want to see where the lesion is typically, whether it's a proximal TS1 or distal TS1. If I see the AVR, AVR is basically showing depression, not elevation. So it must be a proximal LAD, but it's distal to S1. Because if it's proximal to S1 means it should have shown AVR elevation. So here it's distal to S1. But since 1 and AVL is basically showing elevation also, it must be proximal to D1 because D1 also is getting seriously ischemic. So this is the diagnosis. So it's a proximal LAD lesion, not proximal to S1, distal to S1, but proximal to D1. So that's why it's showing this kind of picture. Very, very simple, as simple as that. So what is this one? It's an interesting one, curious one, isn't it? What you're seeing here? Again, a hyperacute T waves only, but where you're seeing hyperacute T waves and what is the MI that is seen? Yeah, proximal to S1, we would have seen anterior wall, I mean, RBB. That is, there is no RBB there. So it's not proximal to S1. Ishan is correct. Okay. So what is MI here? So you're seeing in V1. Okay, V1 elevation is there. V2 also elevation is there. And V1 already Q waves have started forming. You can see a big Q wave here. And ST elevation, I mean, these are hyperacute T waves more than ST elevation. So you have ST elevation, you have ST elevation, you have hyperacute T waves are ST elevation. You have ST elevation here. So it must be more of an anterior wall MI. There's no doubt about that. It's an anterior MI. But take the V5, V6 and all. V5, V6 is not showing significant elevation. 1 and AVL is also not showing significant elevation. So which means your diagonal branch, the first D1 is not really involved. So that itself tells its lateral wall is not that involved. And which means that itself tells that it must be most probably a distal lesion. But let us confirm it. To confirm it, if I want to show the 2-3 AVF, see the 2-3 AVF. 2-3 AVF is actually showing some elevation. Suppose if 2-3 AVF is showing elevation, it is an anterior MI. Along with that, if 2-3 AVF is showing an elevation, then it must be a distal LAD lesion because that's how we find out. So if it's an LAD lesion because anterior MI, proximal versus distal. So I'm going to see the 2-3 AVF. 2-3 AVF, if there is ST elevation, usually it goes towards a distal LAD. So it must be a distal LAD. And similarly, if 1 AVL will not be involved, there will be no involvement of 1 and AVL, V5 and V6. The most lateral portions will not be involved that much in a distal LAD lesion. So typically it will not only cause anterior MI. So that is typical of a distal LAD lesion, which is very clear about that, which you have discussed already. And what about this one? This is a very tough ECG basically. Not easy to find out, but if somebody finds out, I'll be mind blown. If you tell the full diagnosis, very tough. So I know it's a tough one. So first of all, it's not anterolateral. To be honest, first of all, you're seeing only the Q wave here. This is substantiate the fact that this is the old MI. You don't see any ST elevation. You don't see any significant ST elevation in any of these anterior leads. But one sign of an old MI is you see only the Q waves. Only Q waves, no ST elevation, which means this patient had an old anterior MI. This is not a current MI. Yeah, poor progression of R waves and you have a Q wave, of course. So that's an old anterior MI. So this area is old anterior MI completely. So which means previously he had an LAD occlusion. Previous LAD involvement was there. And it must be proximal LAD involvement. Now, what's happening is now is you're seeing an ST elevation in 1 and AVL. I think you can see it. In 1 and AVL, you're seeing ST elevation. You're seeing 1 and AVL. No. No. The number, somebody is having number 1116-11007. I mean, change your number, man. I cannot call you. So, doctor, some number is telling that it's left ventricular aneurysm. No, left ventricular aneurysm will have ST elevation in the involved area only. It will not be having in a new lead. New lead means definitely it is a high lateral MI. Whenever you get an isolated high lateral MI, it must be D1 involvement. So this patient is having a new diagonal branch involvement of LAD. And that is very clear because he already had an LAD, and it's logical to think that this patient is now having a D1 involvement. Already LAD is gone, now the diagonal branch is also gone. He's getting a this kind of involvement. So you can confirm it's an LCX for sure because you're seeing ST depressions. Because as I told you, if it's a LCX involvement, your 2-3 AVF definitely will have, depression only. Only if it's RC involvement, 2-3, this thing is more towards the left side, it must be this thing only. So transanterior MI. I don't know what is meant by transanterior MI. So this is a high lateral MI, should be D1 of LAD. That's all, as simple as that. Diagonal branch, which I've told you already. You can go back and see. So what is this one? This is not a septal MI. See, how can you see? I told you 80 milliseconds, Niharika. 80 milliseconds from the J point. There is no ST elevation at all. How can you tell it's anteroseptal or septal? There's absolutely no ST elevation in any of these leads. But there is some ST elevation and T wave inversion that's happening in the 1 and AVL. So 1 and AVL is showing some ST elevation and T wave inversion. And here there is a Q wave ST elevation and T wave inversion in AVL. So which means you have only 1 and AVL involvement. There's no other involvement, which is still a high lateral MI. But the beauty here is, if you see 2, 3 and AVF, they are isoelectric. So if 2-3 AVF are isoelectric, then it must be circumflex involvement mostly. So V2 and V3, I don't think. See, I told you, V2 and V3, you should have at least more than 1.5 to 2 millimeter. Then only you can tell. Are you seeing any 1.5 2 millimeter? So this is the J point, and I think not even 1 millimeter is seen. So there is no elevation in V2 and V3 here. So you have a good R wave also. So that's not the case. So this is not a anterior MI. So this is a high lateral MI. High lateral MI, you don't see any ST depressions in 2-3 AVF. Isoelectric tells you that it's a LCX involvement more often. If it's a ST depression that you're seeing in 2-3 AVF, along with 1 and AVL, that's a D1 branch. I told you already. All these things have been discussed already. It might be confusing, but it's fun to know all these things. What about this ECG? It's an easy one again. First of all, where is the MI that you're seeing? This shows multiple ideas. What is this? Of course, it's an inferior MI. You can see elevation here. 2, 3, a little bit of elevation is there in 3, but definitely in AVF you have some elevation. There's no doubt about that. So 2, 3 AVF is surely showing elevation. So 2, 3 AVF. So it must be an inferior MI. If it's an inferior MI, so it must be either a right coronary artery or a left circumflex. Where you are seeing elevation more. In 2 you are seeing elevation more, or 3 you are seeing elevation more. 2 you are seeing elevation more, or 3 you are seeing elevation more? Where you are seeing elevation more? Yes. 2 you are seeing more elevation compared to 3. And come back to the 1 and AVL. In 1, wow, you're actually seeing ST elevation. So in fact, 1 plus or minus a little bit in AVL, you're seeing ST elevation. You're not seeing any ST depression. That itself confirms it's LCX and it cannot be RCA. RCA will show only ST depression in 1 and AVL. And this patient is not only having inferior MI, this patient is also having, I said, posterior MI, because you can see in V1 and V2, you're seeing a bigger R wave, which should not be the case, because in every previous ECG, you see it will be a small R wave in V1, V2. You're seeing a little bigger R wave with a ST depression and a upper right T wave. So this is a mirror image of what is happening on the posterior wall. So this patient is having not only inferior MI, this patient is having a posterior MI. So you can understand this 1 and AVL elevation is more suggestive of a lateral wall MI. So if the patient is having the patient is having posterior lateral wall MI, it is equal to LCX. Only this can produce this lateral elevation. So LCA, one elevated means itself it's LCX only. It cannot be anything. It cannot be RCA for sure. Here you are seeing posterior wall MI also, which is the mirror image you are talking about for a long time. So this is an inferior posterior lateral because of LCX. This is very difficult. This I have not told you, so I will talk about this later on. I have one more ECG to show. So I wanted to show, but it's not there, I think. Okay. Fine. So what is this basically? So this is very tough to predict. Here, only one clue is there, that you're seeing elevation only in the AVR. You don't see anywhere else. Only AVR elevation is there. So you don't see any other elevations. And you're seeing a lot of ST depressions. For example, in V4, V5, V6, then in 2, 3, AVF, in multiple leads, 1 AVL, everywhere you're seeing ST elevation, ST depression, and only one lead that shows AVR elevation. Only one lead that shows elevation is AVR. So whenever you have AVR elevation, plus or minus V1 ST elevation, and other leads are showing ST depression, what does this predictive of? What is this predictive of? Somebody told the right answer already. So this is actually predictive of a LMC occlusion, left mainstem occlusion, or it can be sometimes a significant 3VD. That's called a triple vessel disease, LMC occlusion. So this is something I needed to tell. So whenever you have an LMC occlusion, you will be usually having AVR elevation more compared to the V1 elevation. And typically, sometimes even in triple vessel disease, you can see something like, so you obviously need a coronary angiogram to confirm this. But whenever they give some ECG like this and patient is coming with chest pain, LMC occlusion. Remember, always don't forget to see the lead AVR. That's really, really important. If AVR is elevated, all the other leads are showing some amount of depression. It must be an LMC occlusion. What about this one? What about this one? This is another different set of an ECG, but this is just to confuse you. Another form of ECG. What's happening here? What's happening here? Here also you're seeing elevation. AVR is elevated. Okay, all right. But what else you're seeing here? Yeah, it's not hyperkalemia or hypokalemia. We're not talking about potassium here. I wanted to see the elevation. So V1 also is showing some elevation. Okay, V1 is also showing some elevation. But more importantly, what you're seeing in V2 is also elevation. You're seeing a QA with an ST elevation in V2 also. So this is not a simple LMC occlusion. This is an anterior MI only, for sure. But anterior MI that shows AVR elevation. Where will you see? This is an anteroseptal MI, but they are having AVR elevation. Where will you see that? Absolutely. This is proximal to S1. So this is LAD proximal to S1. This is not an LMCA. So that's why it's very important to see where you are really seeing. See here V2 is not showing any elevation. This is not an anterior MI. So when you do not have an anterior MI and you have AVR plus or minus V1 ST elevation, then you can think about LMC or 3-vessel disease. But if you are having V2, V3 and all ST elevation, in that if you see AVR elevation, that goes towards a LAD occlusion proximal to the S1 branch. It's not like RBB should always be there. RBB, if it's there, it confirms, but it may not be there. We cannot really predict that. So that's something that is very important to understand as well. And this is also very important. This is something which I have not discussed yet. This is something called as a Wellens phenotype or a Wellens syndrome. So there are two types of Wellens syndrome. This is basically a type A Wellens syndrome, this particular ECG. Type A Wellens is a biphasic pattern that you will see in V1 to V4. Predominantly in V1 to V4, that's what you will see. That's a biphasic T wave pattern. So whenever you see this kind of Wellens pattern, that typically tells you there is a critical LMCA or proximal LAD occlusion. So usually it goes towards a proximal LAD only. So which means the LAD is having a critical stenosis, which means in some time or maybe within weeks or within days, they might get a STEMI. It can be like a precursor. So it's like a warning sign. The patient will come with a chest pain, Wellens sign is there. So think about if you don't treat right now and don't do a coronary angiogram right now, the patient will go for a myocardial infarction within a week or maybe within days also, within hours also. So it's a sign of an urgency again. It's not a STEMI, but still it's a sign of an urgency. So you can see some kind of a biphasic pattern here. Some kind of biphasic pattern. Remember, biphasic pattern means initially it should be positive, later on it should be negative. So this kind of biphasic pattern only you can call it as Wellen pattern. Clear? Initially it should be positive, later on it should be negative. So let me come back to that. Initially it should be positive, later on it should be negative. So only if you see this kind of pattern, this is a Wellens pattern. Suppose let me give you a trivia. Suppose if you are seeing a negative and then a positive like this. This kind of biphasic T wave, what is that? Negative, positive kind of a biphasic T wave. So what does that goes for? Usually this goes towards something called hypokalemia. So don't diagnose Wellens there. Wellens means initial should be positive, later on it should be negative. So if you have an initial negative, then positive, then it's likely to be a hypokalemia. So don't diagnose that. So this is a Wellens phenotype. Wellens always indicates a critical LAD occlusion. They'll go for STEMI in a short while. So this is a type A Wellens pattern. Then we have another type of type B Wellens pattern. In type B Wellens, you will see this kind of deep symmetric T wave inversions. If you have this kind of deep symmetric T wave inversion, the precordial leads, especially from V2 to V6 or V1 to V6, that is suggestive of a type B Wellens. And that is also a sign of a critical LAD occlusion or a critical stenosis of the proximal left antedesigning artery where the patient is about to go for major. Devented T waves are different. I mean, why you want to really ask about devented T waves for a NEET PG, man? That's absolutely a PG discussion. There's no need for devented T waves in PG. That's an early sign of ischemia, but that is not something that should be really discussed here. So this is type B Wellens. Because Wellens have been asked before, I'm talking about because JIPMER questions usually ask about Wellens. The 2-3 times they have asked in JIPMER already. Type B is nothing but, deep symmetric T wave inversions in precordial leads, especially V1 to V6. We see these kind of deep symmetric T wave inversions. This is not a deep Q. This is a deep T wave. Like this is an RS, and after a QRS complex, you get a T wave only. I'm shocked. This is not a Q. This is a T wave. This is a deep symmetric T wave inversion. This is valence type B. Type B valence. This is type A valence, biphasic T waves. This is type B. Riju, some 5 minutes, I'll give a break. And this is something I don't want you to tell right now. And what about? Yeah, this one. So this one is a example. Kindly where to check for a J point. See, 80 milliseconds from the J point is where you have to check, which means 2 small boxes. 2 small boxes from the J point. Clear, sir? That is where you have to check for the ST elevation, the ST depression. Clear? Okay. So now what you're seeing here is a subendocardial ischemia, which means you're seeing only T wave inversions. Only T wave inversions. Nothing else. In the lateral leads, and you're seeing in the 1 and AVL. So this is typically suggestive of a subendocardial ischemia. In this setting, usually I'll be diagnosing an acute coronary syndrome. That will be a NSTACS. That will not be a STACS, because here you're seeing only T wave inversion. This is an end-STEMI or an unstable angina complex. So this finding usually more goes towards a unstable angina than a end-STEMI. Whenever you see only T wave inversions, only isolated repolarization abnormality, so then it must be a less severe form of end-STEMI, that is an unstable angina. Then if you see a more severe form of, this thing, ACS, this is end-STEMI basically. So how you find out is because here you're seeing actually ST depressions, but an upright T wave. Whenever you have an ST depression with an upright T wave, that is actually said to be an evidence of an infarct, because ST depressions are sign of an injury current. So which means they are more ischemic. Only repolarization abnormality, okay, fine, minimal ischemia. If you're having an injury current itself, which is a sign of when you have an ST depression, that is a sign of a severe injury and a severe ischemia. So this usually moves towards a severe form of NSTACS, very likely to be an infarct. But remember, infarct cannot be diagnosed unless and until you use the troponin values and you see the troponin values are elevated. So no need to comment all these things here. So this is a more severe ischemia. That's all, where you're seeing ST depression multiple leads. You're seeing ST depression here, probably here as well, in many areas. So this ECG is purely about ST depression, but you can see the T waves are basically upright. So this is a sign of an injury current, which is a more severe ischemia. So you can see T wave inversions, NSTACS, ST depressions, NSTACS. So ST segment depression is of 3 types. One is called an upsloping type of ST depression. So basically you have the J point here, which I've drawn. Then from two small boxes, if you take the ST segment that is somewhere around here. So if you connect this, the slope is upward. So this is an upsloping ST depression. On the other hand, if you take the J point, which is here, and 80 milliseconds from the J point, so it is somewhere here. So if you connect these 2 lines, it will go like this. So this is a downsloping ST segment depression. And if you take the J point that is over here, junction of the ST segment, QRS complex with the ST segment, then if you take 80 milliseconds, that is 2 small boxes from the J point. This is the point where you have to measure the ST segment depression, where if you measure if you draw a line, then it will be straight. It is horizontal ST segment depression. Remember, upsloping ST segment depressions are okay, not dangerous. Whereas downsloping or horizontal is going to be very bad. It's going to be dangerous. This is what is the basis of our treadmill ECG also, which we'll be discussing in the afternoon session basically. So ST segment depression, upsloping, not a problem. It's very common. It can happen in tachycardias itself, but downsloping or horizontal ST segment depressions are dangerous. That's not good to have. So I think now this localization must be easy, isn't it? ST elevations and ST depression, all these things. So with this, I think we can give a break for you. Is it okay? Lunch break right now. So I think you have any doubts in localization of the culprit artery. This much only I can tell, because too much is there to discuss about the culprit artery localization, but this much I feel is more than enough. How long you need a break? Maybe you can come back at 2:30, 2:45. Maybe at that time will be fine. Maybe 1 hour. You can take rest and you can come back. That must be fine. Right? Yeah, 2:30, 2:45. Cool. So that time you can come. So this particular session we have discussed on the ECG, STEMI and the artery localization, and enough of this. So I think I'm not going to discuss about the arteries anymore. And I mean, you are understanding this, right? So it's at least you can get some idea. You have to, of course, discuss on more ECGs, but I think this must be more than enough. Injury vector is decided based on the injury current. How much big is the injury current and which direction injury current is there. So, I mean, you might be as a preliminary level when you are thinking about an undergrad level. What do you think is if inferior wall is damaged, you should have the injury current down only. That's correct. But if the lateral is also involved, the injury current will be directed somewhere here only. So 2-3 AVF may show lesser ST elevation compared to that of what only the inferior MA is having. So that's how you have to think about. So it's about the vector principle. So when there is a vector that is going like this, there will be perpendicular two vectors going side by side. So let me finish off with this particular concept. So this is really, really important. Suppose if you have a positive and you have a negative, I mean, I can write it in reverse. If you have a negative and then you have a positive, and let us assume this is the, way how you find out. This is the way how you find out. Suppose, let us assume there is a vector that is traveling in the same direction, negative to positive, in the same direction as that of your the cardiac axis. I mean, the vector is passing the same direction as that of that particular lead. So the recording lead, suppose if we take this as a recording lead, what will be the deflection? Because this depolarization wave is traveling towards that particular lead. What will be the deflection in that recording electrode? Positive or negative? Of course, it's going to produce a positive deflection. And more importantly, it's important to understand that it's going to produce a full positive deflection like this. Let me take another example. You have a positive, negative, and a positive electrode. Positive is always the recording, we know that. And this is this thing. And now I am talking about vector, depolarization vector that is moving away from the recording electrode. So in this section, exactly away. So what will be the deflection in the recording electrode? It's going to be full negative. So which means here the angle is 0 degree. It is full parallel. Here the angle is 180 degree, which is full reverse, opposite. So that's why. So at 0 degree, you will get a full positive. At 180 degree, you are going to get a full negative, depending on the direction of the vector. Similarly, negative and positive, you are having the recording electrode at the positive side, and something is moving at an angle like this, perpendicularly like this. So now how you can understand is whenever something moves perpendicularly like this, so there's going to be some force acting on this side. There's going to be some force acting on this side. So because equal amount of force are acting on this side as well as this side, that's why it's going straight. So this recording electrode, some part is moving towards the recording electrode and some part is actually moving away from the recording electrode. Away from the recording electrode as well. So of course, this is going to generate a positive and a negative deflection. So which means typically you will have something called a biphasic wave. This is a biphasic wave. So at 90 degree, exactly the depolarization vector is at 90 degree to a particular recording electrode, perpendicular to the recording electrode, then it's going to show something called a biphasic pattern. That's something critical to understand as well. Then if it goes at an angle, what will you do? Suppose if it goes at an angle, let me draw like this, and this is a recording electrode. And if it is going to go at an angle like this. So now if you take the vector here, the angle is less than 90 degree, all right. But if you see why it is slanted towards the right side, because there are more vectors acting towards this side compared to the number of vectors acting towards this side. So since more vectors acting towards the recording electrode, you are having you are going to have a predominantly positive deflection and a small negative deflection here. Why predominantly positive? Because more is towards that recording electrode and a little away from the recording electrode. So that is why you are getting a predominantly positive, but a little negative as well. But similarly, if this is recording electrode and if your depolarization vector is like this, which means here the angle is obtuse, more than 90 degree. Angle is more than 90 degree. In this situation, you can see there must be a lot of forces that are acting away from the recording electrode. And some forces are acting towards the recording electrode as well. So which means in this situation, since more are acting away from the recording electrode, so now it should be small positive and a big negative. So this is really important to understand, because this is how you're going to find out the axis later on when I'm going to teach about the axis. This shit. Talk about the axis. So which means if the angle is 0 degree, full positive, 180 degree, exactly opposite, full negative, 90 degree biphasic. If it's less than 90 degree, predominantly positive, less negative. If it's more than 90 degree, predominantly negative, less positive. So this is how you're going to think about. And this is how we are going to find out the cardiac axis itself in the first place. So I think it's better, since I've told you this, I'll just tell you the cardiac axis alone, that how to find out the axis using just 2 leads. Just hold on for a while. Let me draw a circle. Okay. So fine. So now you know you are having a lead 1 at this point. You know you are having a lead AVL at this point. And you know you are having a lead 2 at this point. You know you are having a lead AVF at this point. And you know you are having a lead 3 at this point. And you know you are having a lead AVR at this point. But really don't know the angles, which I have not told you till now. So with this understanding, it's better that we discuss about the angles also, which means at lead 1, 0 degree, we know that it's straight parallel, and lead AVL is at minus 30 degree, because it's a little anti-clockwise. Lead 2, it's plus 60 degree, and lead AVF is plus 90 degree, you know that, and lead 3 is plus 120 degree, and the lead AVR is at minus 150 degree, you know that. So it's anti-counterclockwise, so again it is at minus 150 degree. So we can put 2 arbitrary lines like this. So here and here. So this is a line at 180 degree, but there is no, this is a line at 180 degree, but there is no vector that is, there is no lead that measures that area. And this is an arbitrary line, hypothetical line that I have drawn at minus 90 degree, but there is no lead over there. Just to confirm what is mean by left axis deviation, what do you mean by right axis deviation. If you want to know what do you mean by normal axis means this particular zone. So this zone is what I'm going to call it as a normal axis basically, which means based on the shading itself, you can tell what do you mean by normal axis. Normal axis means you're going to have your axis between minus 30 degree to plus 90 degree. We are talking about the net cardiac axis, net electrical current of the entire heart. We are not talking about a particular electrical activity. We are talking about the net activity. In fact, the ventricular activity, the overall ventricular activity is what we're going to talk about. So net axis is minus 30 to plus 90 degree. This is a normal axis, definition of a normal axis. Suppose if you're going to have your axis, the net electrical axis is going to be in this particular direction. So this will be called as a left axis basically. Left axis. Most often this is also referred to as something called a superior axis. I'll tell you superior axis is a little different. Left axis is superior, but I'll tell you what is that. So superior axis also, which means it's somewhere around minus 30 degree to minus 90 degree. So this is superior axis or left axis. And then we can have the right axis. I think I have drawn this one wrongly. 1 second, man. Minus 30 to plus 90. So this is where I have to draw. Sorry for that. Even I am hungry, I think. Okay. Fine. So then we have the right axis. Right axis should be somewhere here. Right axis should be somewhere here. So right axis means it should be somewhere around plus 90 degree to 180 degree. So this is the right axis deviation. So right axis deviation is plus 90 to 180 degree. Then comes the last but not the least. This is something very crucial to understand as well. So this is usually the cardiac axis will not be in this location at all. So this is referred to as something called as an extreme axis. Extreme axis, or typically since it's in the northwest direction, it is also referred to as something called a northwest axis. So if you want to know the where is the northwest axis? Somewhere around minus 90 degree to 180 degree. So in the counterclockwise direction. So this is a northwest axis. Usually you don't get cardiac axis in this location. Only two conditions can produce cardiac axis in this condition. So this is extreme axis deviation. So on the extreme lead is AVR, that is a northwest lead. That's the only lead that is located in that particular zone. So right axis, most of the people do call it as inferior axis. But I mean, that's a different thing. So you should not really call it as inferior axis. Inferior axis is something different. So for example, so if you take this one, so this is superior axis. So on top of the gold superior axis, and on the down, whatever is there, I'm going to call it as inferior axis. Clear? So if you talk about superior versus inferior axis, you have four things. So you have left superior, left inferior, right superior, and right inferior. So you have four types of axis: left superior, left inferior, right superior, and right inferior. So since left axis is in the superior location, so that's sometimes referred to as superior axis, but that's wrong. This entire area should be called a superior axis. But left axis is also located there. So that's a superior axis basically. Similarly, northwest axis is also superior axis. It's not an inferior axis, which means northwest axis should also be called as probably a right superior axis is what we refer to as a northwest axis basically. So these kind of terminologies will be confusing when you read a textbook, but when I tell it will become easier. That's why I want to tell this. So don't get confused between superior and inferior axis. Similarly, it is an inferior, right axis is an inferior axis only, no doubt about that. But you can clearly see it's something like a right inferior axis. That's why right axis deviation, sometimes it's also referred to as an inferior axis. It's a right inferior axis. Similarly, remember, normal axis can be left inferior axis or left superior axis. Remember, you should be little bit careful on the terminologies. Okay, little careful on the terminologies what we are discussing. So clear? So when you want to go for the superior inferior nomenclature, use this diagram which I have told you. When you want to tell right, left, northwest, normal, go for this nomenclature which I have told. This is really, really important. So this should be used if you are going to use right, left, normal, northwest. This convention you have to use if you're going to use superior versus inferior axis. So this kind of superior, inferior and all will be very useful when you're dealing with the ventricular tachycardia. So that time this will be very useful. Unless and until you're not dealing with the ventricular tachycardia, it's not going to be useful. And for all the common purposes, this is the axis that you have to answer in the exam. Normal, -30 to +90. Superior, -30 to -90. So I can write here again, -30 to -90. That is left axis. Then right axis is +90 to 180 degree, and northwest axis, extreme axis is -90 to 180 degree in this location. So all these things have been clear now. So how to really find out an axis? So you're going to have a rule. So we know that. That's a very simple rule. For example, if you really see something, so I'm going to assume now. So assume now that the cardiac vector in this is in this particular quadrant. So this quadrant, where it belongs to, this quadrant belongs to normal axis. We know that. So now I don't know whether it's normal axis or not. Now assume first, you're assuming that your electrical vector is located in that particular quadrant. If it's located in that particular quadrant, there are two leads that are there, 1 and AVF. That's what I'm going to use. So now first my assumption is there. I'm assuming that my electrical axis is in this quadrant. If my electrical axis is in that particular quadrant, of course, if you see this is the recording electrode, if you take that as a recording electrode, then the angle between 1 and the cardiac axis or the electrical vector, very clearly it is less than 90 degree. If it is less than 90 degree, of course, one must show predominantly positive deflection. And similarly, if you take AVF is also showing less than 90 degree. And of course, AVF also should be positive. Now I know if the cardiac vector is located in this particular direction, I'll be getting a combination of plus and plus here. Clear? So AVF will be predominantly positive and Riju, I need some 3 minutes. Wait on. So I'll give it 1:45 sharp. So one positive and AVF positive, both are there. So if one is positive and AVF is positive, both are positive. In this situation, I can conclude that the cardiac axis is in this quadrant only. And now this can be reversely assumed that it must be a normal axis. Then suppose second assumption, let me assume that my cardiac axis is in this particular quadrant. This particular quadrant is going to belong to the right axis for sure. But let me assume that the cardiac vector is in this axis. Now you have two leads, that is 1 and you have a lead AVF. So now you clearly can see that the distance between, the angle between the lead one, if you take this as a recording electrode, the angle between 1 and the cardiac axis is more than 90 degree here. Since it's more than 90 degree, 1 should be negative. And you can see the angle between, if you take this as a recording electrode, now the angle between AVF and the cardiac axis must be less than 90 degree, and this should be positive. So whenever one is positive, AVF is positive. One is negative and AVF is positive. So you can assume that the cardiac axis is in this particular quadrant, and this quadrant typically belongs to right axis, and I'm going to write this patient is having a right axis deviation. And third rule is suppose if this patient is having an axis in this particular quadrant, so you have the same 1 and AVF here. So now you can see this quadrant typically belongs to, for the northwest axis. So whenever you think about a northwest axis, so if you take the angle, this is the recording electrode. Now if you take the angle between 1 and the recording electrode, 1 and the cardiac axis, now it is definitely more than 90 degree. So 1 should be negative. And of course, if you take from any direction, if you take angle between the AVF and the electrical axis here, because it's in that quadrant, it should be negative as well. So whenever 1 is negative, AVF is negative, I can assume that the cardiac vector is in this quadrant. So if it's in that quadrant, then definitely it must be a extreme axis only, or we can call it as a northwest axis. One of the important evidence of northwest axis, AVR will be usually positive. It will be full positive most of the times. It will be showing a full positive deflection. Whenever you see AVR full positive, it goes towards the northwest axis. Final, last but not the least, suppose if you have, this is a tough thing to understand, because if you have axis in this particular quadrant, so now we know if it's in that particular quadrant, if you take 1 and AVF, the angle between 1 and AVF will be definitely, 1 and cardiac vector will be usually less than 90, so it must be positive. But angle between AVF and the cardiac axis is definitely more than 90 degrees because it's crossing one full quadrant, so it must be negative. So if you see a combination of 1 plus and AVF is negative, so then it gives rise to a confusion, because this quadrant, if you take this particular chunk of information, this particular quadrant, if you take, it is shared by 2. By normal axis as well as left axis, is shared by both. So since it is shared by both, so I should write it should be either normal axis or it should be a left axis. Both can come in this entity, between normal axis as well as the left axis. So how will you find out whether it's a normal axis or a left axis? In this situation, I'm going to use the isoelectric principle again. So I'm going to see the lead 2. So see the lead 2, and lead AVL is somewhere here. Leave the other thing, so that I don't want. So lead AVL is here. So we know lead AVL is at minus 30 degree. Lead 2 is at plus 60 degree. And very well the angle difference between lead 2 and lead AVL will be together around 90 degree. 90 degree will be the angle difference between the lead AVL and the lead 2, which means minus 30 to 0 is over 30 degree. And that 0 degree to plus 60 is another 60. So 30 plus 60 will become total difference of 90 degree between lead AVL and lead 2. So that's what I'm going to use. So how this principle will be useful? Really, it is very useful. Trust me. Suppose if the cardiac axis is in this quadrant, suppose, in the particular quadrant that we are discussing only, but if it is within the AVL, then in this situation, definitely the angle difference between lead 2 and the cardiac axis should be less than 90 degree, because we know difference between AVL and lead 2 is 90 degree. If the cardiac axis is present in this, is a depolation vector is present in that particular area, then definitely it should be less than 90 degree. So here, if you see lead 2 will be surely positive. In that setting, I can conclude it's a normal axis. Suppose on the other hand, if the cardiac vector is in this quadrant, so let me draw in a different color to avoid confusion. So the cardiac vector or depolation vector is in this area, the same quadrant what we are discussing. But here you can see it's beyond AVL. So definitely the angle difference between 2 and AVL should be 90 degree. So if it's beyond AVL, means the angle difference between 2 and the cardiac axis must be definitely more than 90 degree in this situation. So if you see lead 2 is negative, then I can conclude that this patient is probably having a left axis deviation. It's as simple as that. So I need you to see only 2 leads. I need you to see only 2 leads, 1 and AVF. So 1 positive, AVF positive, normal axis, 1 negative, AVF positive, right axis, 1 negative, AVF negative, AVR positive, northwest axis, one positive, AVF negative. There can be two possibilities. Either it could be a normal axis or it could be a left axis. See lead 2 in that scenario. If lead 2 is showing negativity, then it must be a left axis. If lead 2 is showing positivity, then it must be a normal axis. This principle is what we refer to as something called a quadrant rule or a quadrant principle. And this is really, really important. Why lead to negative left axis deviation? Of course, because I'm not telling. Left axis deviation means because lead 2 is here and AVL is here. So only when you cross this AVL, so when you take the original diagram, only beyond this AVL, you call it as a left axis. Till this, it's a normal axis only. Beyond this AVL, only it's left axis. Suppose you know the gap between AVL and lead 2 is 90 degree. Now here 130 degrees there, here another 60 degrees there. So it's 90 degree gap. So I told you, if the vector is in this zone, so definitely if you take the lead 2, so if you take the lead 2, it is going away a little bit more than 90 degrees. So since it is more than 90 degree away from lead 2, so lead 2 should be negative if the cardiac axis is in this direction. So that's why lead 2 negativity usually is associated with left axis deviation. I think you can get it. It's not a very difficult task to do. So, but even if you don't really understand this 90 degree principle, even though, if you can go back and always read one more time so that you'll be understanding better. Even if you don't understand this better, I'll tell you one thing. So just memorize this. 1 and AVF. So 1 AVF positive, positive, normal axis, 1 negative AVF positive, right axis, 1 negative AVF negative, AVR positive, northwest axis or extreme axis, and 1 positive AVF negative. In that situation, you can have two possibilities. One is normal axis, second is left axis. So if you have a 2 positivity, it means it's likely a normal axis. If you have a 2 negativity, then it likely must be a left axis deviation. So that is the idea behind all these things. Hope you get it. And is there any doubts in this? Do you understand this axis? How to find out a cardiac axis? Yes. So just if you in exam, if you don't understand all these things, just memorize this. That's more than enough. Clear? So let me end the session for now. And for all of you, have a good lunch and come back. So I'll be starting by 2:45 now. 2:45, not 2:30, because I should give at least 1 hour of break. Thank you. Good night.